in the patient so that we can prevent complications. The simple objective in this patient is giving the complex patient the best chance at the reasonable recovery and preventing a routine patient from becoming a complex. So we can see in this picture it's just a simple hernia, and this is so complex hernia with loss of domain and parastomal. We know abdominal wall reconstruction has higher chance of higher chance of complication. In the list, it's put on the second of the list, ranging near about 30 to 40. Near about 40%. In one of the statement given by American College of Surgeons regarding the principle underlying the perioperative responsibility. So what they mention is surgeon is the ultimate responsible for all the outcome in the patient. So like a patient with the obesity or diabetic or hypertensive, we send to the physician, but ultimate responsibility lie on the surgeon. So this is the statement given by American College of Surgeons. And these are the factors which lead to the poor outcome in the complex abdominal wall reconstruction patient, like poor wound mesh technique, obesity, smoking, and diabetes. So we know if we do open surgery in the complex patient, the wound infection range from near up to 50% is the reported incidence. So ERAS program, first clinical data in the literature has been put in 2005, and in 2010 they have formed a ERAS society, and in 2020 near about 680 citation was found. So what is ERAS program? ERAS program, as we all know, we bringing our patient. This involve the pre, intra, and post-operative phase, bringing all the function like GI function, better pain control, early mobility, and preventing or reducing complication. And it start from home to home treatment. Like when the patient came to our clinic, we start working on that. And involve the pre, intra, post-operative, and when we send the patient to home, it continue to that period also. All of we know surgery is a stress causing factor, lead to increase insulin release, hyperinsulinemia, and insulin resistance, protein catabolism. So ERAS is the program to reduce the surgical stress and leading to decrease in the length of hospital stay, complication, and definitely the healthcare cost. And involve the multidisciplinary team. It's not only the surgeon, it involves the anesthetics also, it involves the nursing also, and other paramedic facilities also. If we see by this meta-analysis, what they found, the ERAS lead to complication, ERAS decrease the complication near about 50%, and it's also lead to decrease in the cost also in major surgery. So ERAS Society has formed the guidelines starting from the bariatric surgery to liver transplant, and now they are coming with the emergency surgery. And abdominal wall reconstruction ERAS guidelines is on the way. So do we need ERAS in 2024? So if we see this data just before the COVID, near about 300 million surgeries performed worldwide, producing 25% of complication. So still we can see the best practice is not in use. By this example, we can see just a 1 hour uncomplicated surgery. The fluid given to patient is ranging from 2 to 40 ml per kg per hour. There's too much variability. So if we lead to reduction in the variability, can lead to decrease in the length of hospital stay and complication. This we know from the centuries in the car, automobile industry, and aeroplane industry. We need to decrease the variability among us. So complex patient coming in the different shape as the loss of domain, intracutaneous fistula, mesh infection, parastomal hernia. So these are the complex patient. And so ERAS guidelines is better in this kind of patient. So a systemic review in this kind of complex abdominal reconstruction was done, including all these factors like multimodal pain therapy, IV fluid, and early enteral feeding. And the parameter calculated was length of hospital stay and SSI. So in the forest plot, we can see the length of hospital stay is definitely better in the ERAS protocol, but not the wound complication. So even the patient stays for 8 days or 10 days or 4 days, doesn't matter, but is most of the problem in AWR is complexity, like wound complication. So it's not much better in the ERAS protocol. So we have certain factor, like we need to look up the factor which are non-modifiable, like patient age, sex, which kind of hernia, size, is site. These are the factors we don't have much control. These are the factor in the mid. We can see BMI, tobacco, is nutritional status. We can have control on this. And these are the factors depend upon the surgeon, which kind of surgery he going to perform, which kind of mesh, whether using drain or not. We have much control as a surgeon on that factor. So again, same thing, we most control, what we can control is our surgical quality and technique and perioperative care planning. These are the factors like patient profile and what is our operating facility. We have some control over that. So if you see this data published by the abdominal wall hernia surgery unit, so they calculated the cost in the comorbid patient, and what they found is more the comorbidity producing more complication, producing more cost. And if you see this point, patient with comorbidity without and not getting complicated. So in this kind of patient, we are expending too much money to reduce his comorbidities. So again, the cost increase. Sorry for this poor slide, but this slide they have again from the same unit, the abdominal wall surgery unit. So this chart, they have data before 2012, and this is the patient after 2012. So after 2012, they adding more complexity like Botox, more primary wound healing, and more patient getting posterior component separation. And what they found in the results are, in terms of recurrence, wound complication, patient are doing much better if doing this preoperative workup, preoperative optimization in this patient. So how we can predict the complication, and how do we talk with our patient regarding these comorbidities? So there are some application available. It's a free downloadable application, Carolina equation for determining associated risk. So if you can, what this have is these are the 7 factors is included in this application based on 500 patients. And like if you see this simple chart, like 49-year female with BMI 37, history of multiple ventral hernia repair, diabetic, and history of previous mesh excision, smoker. And if we calculate her CDR score is 65. So after controlling this factor like quitting smoking, controlling the diabetic and weight reduction, his CDR, his complication risk decreased by 20. So this way we can counsel the patient. Okay, at this point, because patient come to us, they want surgery today, not today or tomorrow, too early. So we need to optimize all these factors. So this way we can counsel the patient. So preoperative, as I told you in the beginning, ERAS has 3 phases. Preoperative phase, it involves the nutritional prehabilitation, and in the prehabilitation phase, we need to control all these factors like weight loss, smoking, diabetes. And this is the data. I mean, this is the one statement given by Ryan Harbour, Michigan group, and what they said, optimizing a patient for the functional capacity definitely improve the outcome. And also the psychological factor is also important, because this patient has been operated at multiple places. They have 2 or 3 repair, so they are definitely have some kind of depression or anxiety going again for the surgery. So if you can counsel that part, definitely it will lead to recovery better and reducing the complication. And this chart showing the impact of surgeon adherence, surgeon attitude towards optimizing the patient. If we can optimize the obesity and smoking, then definitely it lead to reduction in the complication. This chart showing the surgeon who are adhered to prehabilitation, they have less all the complication, and serious complication is even less in the surgeon group who are adherent to prehabilitation program. So data are definitely piling up, but not too much data about this rehabilitation program for COPD, diabetic or renal disease. This is the Prisma chart rehabilitation program given by European Hernia Society. And tobacco smoking, definitely it is one of the modifiable risk factor in the complex AWR patient, but it's difficult to predict because most of the patient we receiving in our clinic has a history of smoking. So, and we know from plastic surgery or dermatological data that smoking definitely has lot of effect in the subcutaneous phase. Sorry for this poor chart, but this is the American College of Surgeons database. What they found, near about 170,000 patients, all the complication like wound morbidity, respiratory complication and cardiac morbidity is much more higher in smoker, in patient undergoing complex repair. And this data was published in 2017, and this data is from same database, American College of Surgeons quality improvement program, same database. They took same patient with propensity match score near about 7 centimeter defect, and what they found, there is no difference in the complication rate. But if we see this chart, as because defect size is very small, just 7 centimeter here, if the defect size increases, definitely the complication increase. And we know from other surgery like general surgery, thoracic surgery, urology, that this smoking cause poor wound healing, increase SSI and wound complication. And how much we need to abstinence, at least so 4 weeks must be there. All the data predict that 4 weeks should be there, the smoking should be stopped. Diabetic, as we know, most of our patient, incidence of diabetic is increasing in Nepal. So we can see with this National Surgical Quality Improvement Program for American database that all the patient who was poorly controlled diabetic has all the complication much more higher, minor, major, and length of hospital is much more higher in the complicated diabetic patient. So our approach is we need to bring the HbA1c down below 7 before embarking on the complex surgery in this kind of the patient. Again, obesity is also rising up in our country, near about 20% of the population, and still increasing. So BMI is again, obesity is one of the major risk factors for surgical complication in patient undergoing the open ventral hernia repair. And see, this is a randomized controlled trial in patient receiving prehabilitation, obese patient undergoing prehabilitation program and standard counseling. So what they found, prehabilitation means they have nutritionist, physiotherapist, hernia navigator, and there is a simple counseling in standard group. And what they found, the complication, surgical site occurrence is less in prehabilitation group, just 6.8% versus 17% in standard group. So again, these are the BMI, diabetic, tobacco, and mental illness are the major risk factor for this patient causing complication. So this is again, so what to do with this obese patient? So should we recommend bariatric surgery? This is a controversial topic, whether to do bariatric surgery before. It depends upon the patient to patient, and we need to consider whether hernia is symptomatic or not. And now the data are coming for the stage repair by doing bariatric surgery before and then followed by hernia surgery. Because if we see this diagram, obese patient, the anterior wall closure is difficult, so causing more of the bridging repair. More the bridging repair, chances of complication, chances of recurrence is much more high, 9.5 times higher in the patient with the bridging repair. And from this data from the colorectal surgery unit for the incisional patient developing incisional hernia. So what they found on the preoperative CT scan, the visceral obesity, not the overall BMI, is more important causing the incisional hernia. So we need to prescribe patient a holistic approach for his diet. We cannot tell the patient, okay, go home and reduce 50 kg of weight. We need to go for proper counseling to this patient. Definitely MRSA eradication is important in this group of patient. So preoperative preparation start from, we don't keep patient with the NPO for overnight. So just 2 hours before surgery, we allowed them for clear water. And this is our intra-op strategy: avoid NG tube, goal-directed fluid therapy if surgery is going for 2 or 3 hours plus, avoiding the using short-term anesthesia. And we mobilize this patient as early as possible and allowed orally within same post-operative day. So this is one of the strategy given by European Hernia Society during the intra-op strategy to prevent complication in ventral hernia surgery, like using the chlorhexidine scrub or bath, no touch technique of the mesh should not be touched, and drainage, if it will not cause too good, then it will not cause too harm, drain can be used. And there are too much data is coming for negative pressure wound therapy in this complex patient. And we follow the early fluid reduction. So pain is another important factor in ERAS program. So multimodal pain therapy is should be used. And in the open patient, like when we do TAR, we put a tab block in the just above the transverse abdominis between the IA and TA muscle, the bupivacaine solution. So this was our data comparison in 22-year data, about 50 patients undergoing ERAS pathway and 50 patients undergoing from control hernia width of near about 12 centimeter. So all the factor in the ERAS group, like time to liquid, regular diet, walking, is much more improved in the ERAS group. But there are definitely complications. Patient for coming for readmission is just 4% in ERAS group in comparison to 16%. So in summary, ERAS is definitely have multiple benefit, and it reduces the complication, and we need to optimize this patient in terms of weight loss, tobacco smoking, diabetic and MRS eradication. Thank you.
Covering extensively on the ERAS program in AWR.
Next, I'd like to call upon Professor Randeep Wadhwa. He'll be talking about controversial issues in umbilical hernia, defect size 4 to 5 centimeter hernia, umbilical hernia, TAP, ETAP, Milas, TAM.
Thank you very much for inviting me. And like Dr. Manish mentioned in the morning, this is also my second visit here, and both the times Professor David was kind enough to invite us, and thank you very much once again. When you have a primary umbilical hernia, which is of size 4 to 5 centimeters, and you're planning to do either a retromuscular repair or a preperitoneal repair, then what should be done? What is ideal? So by definition, umbilical hernia would be, if you look at the EHS classification, it would be around the umbilicus 3 centimeters above and 3 centimeters below. So that would be a primary umbilical hernia, and my talk would be revolving around how we can treat this particular umbilical hernia. For diagnosis, clinical examination you would all see in your OPDs, and you can examine that. If you still want further investigations on to know further about the status, the size of the defect, then CT scan becomes the most diagnostic test to basically diagnose as well as see the defect and plan your procedure. So what should be the preferred laparoscopic endoscopic repair? Now if you look at this, it basically tells you that there are novel laparoscopic and endoscopic techniques which are available, extraperitoneal, preperitoneal, but there is insufficient data. As on date, insufficient data to suggest that one technique is better than the other. So I'll be discussing about 4 techniques. IPOM has already been discussed by Ashwin, so I'll be discussing the other 4 techniques, that the retrorectus and the preperitoneal, but there is insufficient data to suggest that one is better than the other. Mesh would either be placed in the preperitoneal space or in the retrorectus space. A mesh overlap of at least 5 centimeters is what has been recommended, and this is the algorithm. So this is a nice algorithm, which is the guidelines which were published by the European and the American Hernia Society. So let's just look at these 2 points here. 4 centimeters, and we are planning to do laparoscopic. You would need to have it is kind of suggested to be ideal. Pre-peritoneal or retrorectus placement of the mesh is supposed to be ideal. That's one. Number 2, the coverage of the defect should be at least 5 centimeters on all sides. So those are the 2 recommendations. And why is it ideal? So no personal choices, just what is ideal. The ideal is because there's a mesh placement in the retromuscular space, translate into better vascularization of the mesh from both the sides, lesser recurrence as far as whatever data is available as on date, fewer issues of fixation because you really don't need to fix it, or maybe fix it at a couple of points, lesser pain, fewer chances of bowel adhesions because there's always the PRS or the peritoneum which is covering the mesh. Deployment of a cheaper mesh, you can always put in a Prolene mesh rather than one of the coated and expensive meshes. However, that's the caveat. The technique has a steep learning curve, so it is difficult. You need to learn the technique and only then go ahead and do it. So ideal or easier technique would be the one which Ashwin showed, the IPOM. But if you want to go and learn this, it's got a steep learning curve. So let's look at, I'll straight away go to some short videos of ETEP first. So in ETEP, what we do is, if you look at this picture here, your first port is about 5 centimeters from the midline, subcostal, and with a 0-degree telescope, you make the space. Once you've made the space and adequate space, then you make the second port, which is kind of in between the umbilicus in the same line, just medial to the linea semilunaris, same line as the first port, but in between the umbilicus and the first port. And you make this port, and with a harmonic or a hook, you can make more space. So the first difficulty here is to actually get into this space and then to make more space over here. It's not that easy, but you can always do it with a little experience and knowing the anatomy well. Once you've done that, then you make the third port, which is roughly around the umbilicus. And with that, making the third port, you would do the crossover. So crossover is something which Ashwin had explained, and we'll just see how the crossover needs to be done. So you would put the third port here. Once you put the third port here, then the crossover can actually be done by using these 2 ports, and the camera goes onto the third port. The camera goes to the third port. So now the camera has gone to the third port. The hook is in my hand, which is going from the subcostal, and this grasper is from the second port, which is pressing the PRS down. So this cut is being given about 5 millimeter just below the rectus muscle. So once you give that cut, you can actually just keep giving a cut on the posterior rectus sheath about 5 millimeters just below the rectus muscle, and then get the falciform down. Once you get the falciform down, you'll see the PRS on the other side. So if you remember the anatomy which he had shown, you'll see the PRS on the other side. Once you see the PRS on the other side, you can make some bigger cuts, get the falciform down. Once you have the falciform down, you'll see the PRS on the other side. That's where you see the PRS. Make a cut there, you'll see the rectus muscle. Once you see the rectus muscle, you can just increase that, cutting the PRS down, and then put in the fourth port. So we put in a needle. See, you're in the retrorectus space. This is on the right side. So this is on the right side. You put the next port in, and once you put the port in, then the camera shifts to the subcostal on the left side, and then these 2 become the working ports. The right subcostal, as well as the one here, which is in between the first port and the umbilical area. So that is when, and then you can keep going down by leaving about 3 centimeters of the linea alba on top. So you leave about minimum 3 centimeters on the top and keep going down on either side, and that's when you can join the 2 retrorectus spaces, and this can easily be done by a hook. So like I said, you need to understand the anatomy well, and that's when you can get in to do that. So that's the PRS on the right side, and then the PRS on the left side, and you can keep cutting and leaving at least 3 centimeters or a little more of the linea alba on top. That's the linea alba on top. Once you keep doing that, you'll reach where the defect is. So once you reach where the defect is, you see the defect there, and once you see the defect, you can get the defect, just dissect the defect and get the omentum down. And that's the space which has been created. So that's a huge space which has been created. That's the defect there, and you can close that defect which has been shown since morning. We always use a non-absorbable 1-0 barbed suture, and this is a V-lock suture, and it depends on the size of the defect. It comes in various lengths. This is a 15 centimeters, since it's about a 4 centimeters defect size umbilical hernia. It comes in 23 centimeters, 30 and 45. So depending upon the size of the defect, we use this. You really don't need to lock it at the end. And once you've done that, then of course there's a placement of the mesh. Here what we are doing is we are placing a mesh which has got a gripping technology. So gripping technology just fixes to the abdominal wall. You can fix it on the floor or on the abdominal wall. And also I've just covered that area. We actually sutured the defect on the PRS as well. That is again done by V-lock absorbable suture. So absorbable there and non-absorbable for the defect, and that's it. So this is a E-tip RS. E-Mylos was something which I was supposed to talk on. Now, E-Mylos, I don't have any personal experience. It's been promoted by this gentleman here, Dr. Reinpold. And what he does is this is actually known as minimally invasive technique for extraperitoneal repair, less open sublay. So MILOS is minimally invasive, less open sublay. He goes through the hernial defect and then goes into that space, makes a retrorectus, closes the defect here, then gets into the retrorectus space and then exactly does the same what I've shown. But it requires certain specific equipment. He has this E-torch. E-torch is, he has this particular equipment where it is attached to the light source, and then you can see that and do the dissection, and it's a small incision which has been made. Some publications are there, but like I said, it's confined to his publications and maybe one or other. Otherwise, it's not something which is extremely popular, but it is again being done. The next is, I was told to talk about TARM. Now what we are doing, most of our TARMs are the robotic ones. So I'm just going to show you a short video of a TARM. Now in robotic, what we do is we make ports on one side. So we would always make ports on the left side of the patient. So left side of the patient is where we make the ports, but if you are doing a laparoscopic, you can make it cranial. You can make one in the midline and one on each side and then do the procedure. So this would be a little different, and I'll keep explaining why it's a bit different. So this I'm doing it robotically. In robotic, what we do is we make an incision about 5 centimeters from the defect. So you would find the linea semilunaris to be about at 7 centimeters from the laterally. So we go about 1 to 2 centimeters medial to that and then make an incision on the PRS, posterior rectus sheath. But this we are doing it robotically. If I was to do it laparoscopically, I would make it cranially over here. So you make an incision and then you get into the retrorectus space. Once you get into the retrorectus space, then it becomes almost similar to what you saw in E-tip. Get the hernia down, that's the defect there. So I was told to talk about 4 centimeters defect, so this is roughly 4 centimeters. And then you would get into the midline. Midline you would be in the preperitoneal space once you've cut the PRS, and then you go on to the other side. So that's, you've gone on to the other side. It's easier done once you're craniocaudal. It's slightly difficult once you're going from the side, but it just needs a little experience. And then of course, we use the same sutures to close it. So same barbed sutures are used to close it. Closing this robotically is a lot easier, but close this defect, and once we close this defect, then of course a Prolene mesh needs to be placed and then sutured. So we You can either use a pro grip like I showed in the previous one, where it just grips to the abdominal wall. In this, of course, you need to just suture, put a couple of sutures in this, and then you need to close the PRS. You've made an incision on the PRS, so you would need to close the PRS. So this is just putting a few sutures to basically placing the mesh and then close the PRS. So this is how we close the PRS with a barbed suture. Now this is TAM. The difference between this and I showed you a robotic where I went on the side, but if you're doing a laparoscopic, you would make these 3 ports. So this procedure, transabdominal retromuscular repair, has been, the pioneer is Dr. Ashwin Masurkar from India. So he would make 3 ports, and then he would make the incision on the rectus on the PRS somewhere here, and then go down. So what I did was I went on the side and then went here. He would make, this is little easier, craniocaudal, but then you would realize that there are 3 cuts on the posterior rectus sheath. 2 are along the midline, which in any case you would be cutting, and 1 is transversely placed. So you would have a transversely placed where you would cut the PRS, and 2 all along. So that's why you have 2 cuts. You have a T-shaped on the posterior rectus sheath, while in E-tape you will only have 1 all along the linea alba. I was also told to talk about TAP. So TAP, most of our TAPs would have been robotic. So with robotic, it's a lot easier to do those TAPs. TAPs is pre-peritoneal. Pre-peritoneal meaning you're not getting into the retrorectus space. I'm not cutting the posterior rectus sheath. I'm just in the pre-peritoneal space. But then what I've seen is in all our TAPs that we've done here, we find that the ones patients who are a little obese, where the peritoneum is a little thick, the pre-peritoneal fat is a little more, it's a lot easier. Otherwise, you have a lot of buttonholing. Again, when we were doing it laparoscopy, we would find a lot of buttonholing. But now when we've shifted to doing it by robot, the buttonholing is a lot less, and we can easily manage it. But then we choose our patients in which we are doing. There is one more trick that we follow when we are doing these taps robotically. Laterally, we find that the peritoneum is very thin. That's when we'll go a layer above, not into the PRS, but get the transversalis fascia down. It's difficult to find that. You need to have a very, the dissection has to be very proper, but at times you can do it, and you can give those nicks onto with robotically, you can give those nicks on the transversalis fascia, get that down as well. And once you can get that down, you can manage to complete the tap procedure. So this is again an umbilical hernia, which is about 4 centimeters in size. And so this was a tap. The coverage needs to be about 15 centimeters, 5 centimeters on either side. So this is where the thinning of the peritoneum has taken place. Now invariably you would make cuts there. What we are doing is very carefully going just a layer above, getting the transversalis fascia down, just to ensure that you are not making buttonholing here. So we've avoided that, but at times it's unavoidable, and you would make those buttonholes, and then you would need to suture it. So once you've done that, then of course it's similar. You would just need to close it with a barbed suture. This is, like I said, a 1O V-lock suture, and which generally suffices in about a 4 centimeters defect to close it. Anything more, you would require a longer suture, and very easy to do it. So once you've closed it, then we put in a mesh, and this is the practice that we do now normally. We take a vicryl suture. Even in our groin hernias, we've shifted, no tacks, we just put vicryl sutures. There's a vicryl 2O suture. So vicryl 2O, and we just fix the mesh at 3 points. What we'll do is we'll pull the mesh up by the central suture, and then place 3 suture, and just then unroll the mesh. So very easy to do that. A 25 centimeters long 2O vicryl suture helps you to fix it at 3 points, and then it is just closing the peritoneum. The difficulty here is the buttonholing, and therefore this procedure is not become that popular. because we feel that that becomes a challenge at times, and then those buttonholes can become bigger. We've also had an opportunity where we are doing a pre-peritoneal and TAP, and we've had to go into the retrorectus space. So that of course is something which we need to do. So just last few slides, and this is very interesting. Now this is a publication, this is a prospective data which was collected. It was an IGS publication from all the data from Kashmir to Kanyakumari in India, and length and breadth of the country, and about 3 months data of all the ventral hernias which were done in India. Whoever participated, there were almost 30-40 centers. We also participated in it. We were all in that IAGS collaborative. And so we contributed our data, and this is what the data said. Now what is the commonest hernia that you see? So this would be quite similar to what you would see in Nepal or anywhere else in the world. The commonest hernias, that out of the 670, the commonest hernias were umbilical hernias. The defect size, the average defect size was 3.57 centimeters. So that means 4 centimeter hernia was by and large the commonest defect size which you generally would see. Again, how many you would see beyond 8 centimeters? Those are where you would do all your AWRs and so on. The percentage there is about 29 or 30 cases out of 657. So that generally suggests about less than 5%. So we discussed about AWRs, but those are less than 5%. That is what the Indian data suggests, prospectively maintained data. And what was the procedures done for that? So I'm only discussing the 4 centimeters hernias. So what do you do for these primary hernias? All kinds of procedures are being done. So generally, we are still not sure. That is why the controversy that what should be done. Open repair still is the maximum, because government hospitals also contributed their data. IPOM plus is the second most commonest. Yes, pre-peritoneal repairs and retromuscular are also being done. But then, like I said, open followed by IPOM plus were the commonest in India. And this is the data of last year. So not much would have changed. So finally, friends, in conclusions, which one? ETEP-RS, E-Mylos, TARM, TAP, or maybe an IPOM plus, which Ashwin said. So my first choice, if you ask me, would be an IPOM plus for a 4 centimeters defect. But if you still have to go for a retromuscular repair, and easiest for all of you to go around, practice, and then do it, then my choice of procedure then would be an ETEP-RS. And I have my reasons. The reasons are that, an E-Mylos is difficult to do. Like I said, not enough data. TARM, you'll be cutting the PRS at an additional place and then suturing it. We don't know the long-term data on it. TAP would be difficult except for a few patients who are slightly obese, who've got a thicker peritoneum. But all others, I think an E-type-RS is the right procedure. So if you really want to do the retromuscular, learn this well, and this would be the best procedure for you. Thank you.
Thank you, Professor Randeep, for telling us the different techniques of doing umbilical hernia. Thank you very much.
Again, call Professor David Lomanto with lab ETEP indication and benefits.
Okay, let's talk about ETEP. As Dr. Randeep showed you, there is a lot of name. Actually, there is also a paper who define the classification and about where to put the mesh. Unfortunately, the mesh can only put in 2 positions, posterior and anterior, right? Posterior can be intraperitoneal or retromuscular. Then you can call ETEP, TARM, TURP, TARUP. There are plenty. Surgeon, we like to invent anything, but only one thing is important. Where is the mesh? Retromuscular. Correct? Then you can call, Rakesh technique. So that's so now But there is, of course, there is a tendency to move the mesh from outside the abdomen. Even though, because they blame that the mesh inside the abdomen create problem. I use IPOM, I think like Randip since 2000. I never have problem. There are 20 million cases done in the last 20 years. Report maybe are 3, 4, 5, 10, 100, 1,000. But out of 2 million, the incidence is very low. Still, as IHS data show, IPOM Plus today is a gold standard for the technique. And it's the one who can really guarantee to the patient, say, look, at 20 years, you will have this problem. For other technique, at 2 years, we don't know what's happening. Especially with all this component separation and so on. So let's talk about ETAP. But we need to keep in account anything you do when you do an abdominal wall surgery, either 2 centimeter, 10 centimeter, 20 centimeter, you need to restore the abdominal wall continuity. Abdominal wall is important for coughing, for poo-poo, for standing, for anything. I don't go in more detail. Very important. Okay? So you need to reconstitute the linea alba. You need to preserve the vascular supply. You need to preserve the nerves. So you must repair also with less tension, because tension is one of the causes of recurrence. And of course, we know from open surgery that that more dissection you do, more complication you have. We forgot to talk about ETAP complication. When I do ETAP today, I always scare of seroma, bleeding, and everything. It's something that in IPOM we don't really have it. So we should understand also this problem. ETAP has been started initially is a ripstopper technique. It's nothing new. Only that today we can do with a minimal invasive surgery, endolaparoscopic, and so on. So there are few people that Jorge Dias, a South American guy, he described for inguinal hernia to improve the ergonomics. Nothing else, to improve triangulation, because with the TEP in the midline, we don't have much triangulation. And Igor Beliaski then applied the same technique for retromuscular. But we all know that it's a difficult technique to learn, right? We all know that you require 30, 40 cases. Okay. So we do in many cases. We also need to understand that the best indication is for M2, M3, M4. And when you talk about M1, M4, then you can play with different positions. The only thing, one of the challenges I think that Deep show you is the position and the trocar insertion that you have when you do laparoscopic. Because, as I will show you later, there is some difficulty when you do surgery. What equipment we need? Basic equipment. You need to do a lot of suturing. So you must be very skilled, otherwise you better don't embark in it. Position of the patient, especially Asian patient, I don't know, in India maybe like are small. So the space between the ribs and the pelvis is very small. So to improve it, we just open up the patient a little bit. In this way you can expand, have more space. But sometimes patients, they are very small, they are very difficult because the working space is very limited. This is one of the also challenge of the technique. So these are some cases that we do. Usually we try to put the port always on the side. Of course, if you need to put 6, 7, 8 ports, better to do open. Otherwise the patient has plenty of scar. We use a lot of robotic. Why? Because, as I explained you, these are the steps. So with the robot, you don't need to worry about port position. You can put the port anywhere you want, up, down, right, left, because it doesn't matter. You will have the triangulation with the robotic dexterity. So it doesn't matter where you are. you can just put the port laterally, and you can do up, down easily. You can invert your hand right and left. You can invert your vision up and down. In this way, it's much easier to suture. Fundamentally, the steps are access, then create the retrorectus space on the same side where you insert. Usually we enter on the lateral side of the rectus. You don't go too lateral, otherwise you go in the transversal space, then you need to open the linea semilunararis, then become another problem. Then you do the crossover. The crossover you can do either up at the falciform, or you can do down, below the arcuate line. Or you can go from below directly, if you know the anatomy, if you are familiar with the space. So then you need to open the contralateral space. After that, start the reconstructive part that is required all the suturing. So suturing of the diastasis, the hernia, suturing of the peritoneum if you open up, and then place the mesh that is also not that simple, and then we just need to close, put the drain and get out. Why is it difficult? Because when we do suturing, we suture this way is the best way. When you do ETAP from a lateral side, you need to suture perpendicular to you. It's not that easy, right? So that's one of the challenges. That's why what we do, we tend to put more port overall here. But when you go overall, this head of the patient, it's very difficult to stand. You end up with a back pain. The best is to stay between the leg and go higher up. But it's a challenge. That's why robotic is very helpful for you. This is some rule for port placement when you do lap ETP. According where is the hernia defect, you can go in a different position. It's a nice by Victor Rado. I think he drew this, just summarize the port position of the defect. When you have a robot, it doesn't matter because it's very easy to suture. Randip already showed you, I will not show you. But the facility, for example, for Da Vinci, that you are suturing higher up. As a surgeon, you learn to use lower down. So you can mirror the image lower down. And when you go higher up, for example, the falciform ligament, usually the right instrument, you have the ribs, very difficult. So you can invert with the robot your right and left hand. So you can suture using the left hand, but you use your right hand. So that's one of the very difficult things to demonstrate with any randomized trial. I just show you, I think Randip show you, just either robotic or lab technically is the same. So this is a hernia, divarication. We do always a TA block. Usually we do laparoscopic guided. We do the space laparoscopically. Even when we do robotic, we create the space, the entry space laparoscopically because it's much easier until we put the 3 port, and we create a space up to the neurovascular bundle. So it's a vascular plane. It's a very simple. If you are familiar with the plane, technically it's not very demanding like in inguinal TEP, for example, because there's not much anatomy. Right? You can see it's nothing much. You only need to be careful of the neurovascular bundle, the lamp post, right? Many people you can see here, and to injury when you go lower down, to injury the inferior epigastric vessel. But for example, from this technique, I do today with the plastic surgeon the tram flap. So I do the tram flap, and I work a lot with the plastic surgeon because they come to see. So we do the tram, cutting the inferior epigastric vessel and flap up for the partial reconstruction. So from this technique, actually, we learn a lot of new procedures. Then, simply, you go higher up when you see the crossing and 2-3 centimeters below Xiphoid process, you go behind, and then you cross over on the other side. You can see the fiber. When you go around the umbilicus, you can see the crossing fiber. You can recognize it. We try not to enter the abdomen, so in this way you can reduce too close the posterior aspect. Most of the time we are able to do. And of course, this is the result. And patient can go home the same day, compared to IPOM, where the patient has pain, especially for the next 36 hours, because of the stapler on the peritoneum. With ETAP, believe me, the pain from 1 to 10 is less than 2 soon after surgery. Many patients ask me to go home the same day. But what I want to show, I don't know why the slides, I don't know where you went the slides, is the indication. What patient you can do. So if you need to do a simple ETAP, yeah. Simple ETAP, I think any hernia that above 5 centimeter up to 8, 9, you can really do primarily. So when you talk about incisional hernia or complex hernia, the situation is completely a bit different, more complex. Sometimes you need to put an additional trocar inside the abdomen, do a diagnostic lab, because you don't know if the bowel is stuck below. When you go to crossover, you cross over also the bowel. It's not like IPOM you can do in most of the case. ETAP, there are some restrictions. Even you do a patient with the phalangeal incision, in which the lower abdomen is so together, it's not that simple, okay? Especially if you have multiple site hernia, it's also more complicated. So the contraindication most of the time are incarcerated hernia, because you need to reduce. So then you go in IPOM, reduce, and then you go extraperitoneal. Previous retromuscular repair. Even anterior open repair is not easy, because I found the mesh go through and create adhesion. So it's not easy to dissect the retromuscular space. So compared to IPOM, probably the indication for ETAP are only 20–30% of all over the patient compared to the IPOM. Cephalopubic incision also is not easy to do. So because, primary closure, you need to cut through the suture, you need to go and see below the abdomen. That's all my message about indication and benefit of ETAP. Thank you so much.
Mr. Lomanto, for your nice presentations. So now we'd like to open a floor for discussion, a couple of question and answer. We're already running late. So I'd like you to also introduce yourself, introduction while asking a question, so we know who is asking a question. And I'm giving this mic to Professor Mukund for small announcement.
There is an announcement that Nepalese Association of Surgical Gastroenterology is organizing. The abstract submission deadline is February 5, and the registration deadline is February 10. Please, I invite all of you to attend the program or send your abstracts. For details, you can go through the nasc.org.np. Thank you very much. Now you can ask questions.
So my question goes to Ashwin sir. Sir, what is your opinion regarding use of metallic tack in IPOM? What is the current trend?
There are still a lot of people who do use the metallic tackers. Some of them have had pretty bad experiences with the absorbable tackers, so they still prefer to use metallical tackers. But I think absorbable tackers theoretically is better, because even if you have a small nerve entrapment which has occurred, or if you have caused a small injury to the muscle, at least with the 180 days period, it would get absorbed, and probably those problems would tend to settle on their own. Whereas if it's a metallic tacker, then it is going to be there perennially, and that might need some form of intervention for them to give a relief to the patient. That is the major disadvantage which we see.
I think there are no more questions and everyone is hungry. So we announce the end of this program. Thank you.
I would like to thank our chairpersons for smoothly conducting this session. Now it is time to distribute certificate to the presenter as well as chairperson. Thank you, sir. I request Professor Romeo Kanskar, sir, to come forward and do the honor to Dr. Sasim Podel. I request Dr. Sel Rupa Kheti to do the honor to Dr. Suresh Shah and Professor Rakesh Kumar Gupta. Baini, Baini. I request Dr. Rajesh Podel to do the honor to Professor Randeep Wadhavan, sir, and Professor David Lomanto, sir. I request Dr. Kunal Bikram Dev. I request Suresh sir to do the honor to Dr. Rajesh Podel. I request Dr. Alok Dahal to do the honor to Professor Romeo Kanskar. I request Dr. Rikesh Zankarki, in his absence, Dr. Awaz Kafle, to do the honor. And we have an announcement, and it will be.
A reminder again, you will not receive the certificate. So please log in through Clarinet. If the website is not available, it is present in the registration desk. And for the students and residents who are participating for tomorrow's laparoscopic skill hands-on, please register in the registration desk. Also for the quiz competition, because we have to make some arrangements. So please get registered from the registration desk. Our lunch break will be for half an hour. We'll meet after half an hour. Thank you.
Conduct our session, so we request everyone to be present here at auditorium. Welcome back, ladies and gentlemen. We hope you have enjoyed your lunch. And to kickstart our afternoon session, let's extend a warm welcome to our esteemed moderators, Professor Rohit Prasad Yadav from Virat Medical College, Viratnagar, Dr. Narendra Pandit from Virat Medical College, Dr. Ghanshyam Thapa from National Academy of Medical Science, Kathmandu, Dr. Vishnu Karil from Institute of Medicine, Kathmandu. Now, moving further, we hand over our floor to the moderators.
Should we start? So we are already delayed. Now we are going to start the second session. And the first speaker is our respected Professor David Lemento sir. I don't have to introduce him. His topic is loss of dominion.
Okay, thank you so much. I hope you are not. We need to increase this abdominal pressure. It's a bit uncomfortable. Frankly speaking, I don't have experience because mentally I cannot do. No, because I don't want to. I cannot think to put the poor patient with a tube and pump every day. But you do. I don't know. Somebody of you maybe do. So, but it's helpful to lengthen the abdominal wall. But also, on the other side, you also expand the hernia defect. That's one of the issue. Because if you have too much hernia sac, the gas expand the sac, they doesn't expand the muscle. So it's a bit controversial. How will you do? You put a varus needle on the palmar point. Today they use most the left hypochondrium, and then you'll insert 300 ml. It's a stage procedure. You increase daily by daily, like a percutaneous catheter. You can insert the same under CT scan, and then you do a progressive insufflation day by day. Usually it lasts between 3 to 4 weeks. Of course, you add the DVT prophylaxis because you have a compression of the iliac. That's all. What are the side effects? There's escape of gas in the subcu. You can have a pneumothorax, pneumomediastinum, metabolic acidosis. Anyway, it's an all reversible side effect. What are the evidence? It was utilized by Schumpelik in 2000 in a small number of patients with the very big inguinoscotal hernia, just to expand the abdominal cavity to reduce the content. It was showing that it was a complementary procedure. Today we have more data, about 1,000 patients in 50 study, means all small study. And usually they say that are able to close the fascia in 86% without an additional procedure. So it looks like it works. On the other side, we have a chemical component separation with the Botox. Botox, everybody of you knows, it's a toxin. So there's a side effect. It's an off-label for this indication. So you need to use with the proper protocol or with some research protocol or so on, because it's not fully approved. So if you have any medical legal problem, you may end up with issue. So what is the objective? Paralyze and release the muscle and lengthen the lateral abdominal wall muscle. This will allow you to expand the abdomen and reduce the content. What are the side effects? Back pain. When we inject, we ask the patient to wear a binder because the first thing they within 24 hours they complain is a back pain. That's also an indirect proof how much important the core muscle are. So that's why we need to close the defect. So. Very rare allergy. Usually we do 3 to 4 weeks before surgery. The effects start after 7 to 10 days. Good things, it may last after 3 months from the surgery. So we'll allow the reduction of the content. Also after the surgery, patient will have less problem. So it's done, usually we do under ultrasound guidance. We don't do, but many surgeons do. We ask our ultrasonographer to do, and we do 3 injections to block the 3 lateral muscle, external, internal oblique, and transversus abdominis. There is a study showing that even 2 muscles are effective. Also, this will reduce the cost because we use 50 units for each muscle, so 300, total of 300 units. And the cost is about $600 to $700. If you use the Botox that is not coming from China. Why? Because we have 2 patients dying in Singapore because Botox is a toxin. It's not properly done the unit, you may overdose, and the side effects are quite dramatically. So this is how we do, how our radiology do. It's a simple injection, nothing much. You can see the needle, and then you dilute. You inject the diluted Botox. What are the data? We have quite a number of cases published, about 15 studies. You can see by Weisler. But I think the latest one, another meta-analysis by Timmer, published a few years ago with about 1,000 patients. Look at that point. So the lateral abdominal wall muscle lengthening is about 3 plus minus 3 centimeters from each side, so about 6 centimeters. So improve certainly the fascia occlusion and reduce the contraction. We have done about 30 cases, and we inject with the same protocol, and we have done mostly patients with hernia more than 8 to 9 centimeters up to 12 centimeters. Above that, we just go directly for TAP. So we can achieve a very good primary closure, and we are able to do an IPOM plus or TEP, ETAP in most of the cases. You can see, for example, for this CT scan, this is a CT scan pre and post Botox. How can we reduce the size of the hernia defect so allow us to close better like a normal one? It's quite promising. I think probably many of you have tried, and I think probably one of the latest study, where is it, show that this is just published last week, the one on the right side. If you see, this is the two biggest studies just published. So if they compare Botox with the component separation, there was no difference in the effect of a fascial closure in the two groups. So can achieve similar results. So quite competitive. And also in the study on the right side by De Jong, that was just published last week, there is a tendency, so if you do Botox, you do less component separation in patients with complex abdomen. So the data start to come up and seem to be quite reliable and happy. Thank you so much.
Elaborative talk on loss of abdomen. I think question and answer session will be at the end of the session. Huh? So even the second talk will be delivered by Professor Momento sir.
We sorted out the technical issue, so you can follow the program. Right? Look, the technical program also.
Professor Randeep Balwa for his talk on how to widen the abdominal space and TAR. Dr. Balwa, please.
As TAR has been suggested, so more often than not, beyond 10 centimeters, we prefer to do subxiphoid, suprapubic, parastomal, subcostal, which results after a chevron incision or multiple hernia recurrences. So the goals of a component separation here would be the tension-free reapproximation of the linea alba, restoring the normal anatomic relationship of the abdominal wall muscles, the trigeminal muscles, the rectus, offloading the constant lateral pull of the oblique and the transverse muscular system. So those are the by and large goals of the component separation, and this would be done without increasing the intra-abdominal pressure and preventing an ACS. So that's the goal. So first look at anterior component separation. That again was discussed in the pre-lunch session as well during the discussion of the anatomy by Ashwin. And so what we do is if we are doing an open anterior component separation, we'll raise a subcutaneous flap. So it's a huge subcutaneous flap which is raised, and then we go laterally and give an incision on the external oblique aponeurosis and the muscle right from the inguinal ligament up to the costal cartilages. So long incision is given so that the anterior rectus sheath along with the rectus muscle is medialized or is pushed medially. Anything about 4 to 5 centimeters is pushed medially. But and once it's done, you close the midline, repair the linear elbow, and place a large prosthesis. There are some pros, which is wide facial advancement can be done. It has innovated vascularized repair, improves the functional outcomes. Closure of wide defects is possible, but there are the cons. The cons are there is increased chances of SSIs and SSOs. So those are increased surgical site infections and surgical site occurrences like seromas, hematomas, necrosis of the skin. They do take place because you are actually making a huge subcutaneous flap. So if you're doing an endoscopic anterior component separation, then it works well. But if you're doing an open anterior component separation, then all these problems occur. And that's why more often than not, most people have shifted to posterior component separation, where at least the skin problems or the SSIs and the SSOs don't happen, or happen a lot less. This is an old publication, and let's just look at this data, leave alone the other data because some of it ACS was done without placing a mesh. Let's look at this data here, which was published in 2010, 545 cases, and what they found was they had reasonable number of wound complications as well as the recurrences. Of course, these were all clean contaminated and large hernias, complex hernias, but at the same time, this was quite significant. And that was one of the reasons why people have moved on to doing the posterior component separation. Now again, this was discussed in the morning. That's just the anatomy of the abdominal wall. So what happens, how do we do a posterior component separation? We make an incision just lateral or just below the midline here on the posterior rectus sheath, about 5 millimeters just below that. And this incision is made here, and then we go into the retrorectus space. So if we go into the retrorectus space only up to the neurovascular bundle, and on both the sides, this would be what is called the Reeves-Stopa repair. But in TAR, we would need to go beyond it, because if the hernia is large, we are talking about hernias beyond 10 centimeters, 12 or 14 centimeters, or let's say even after a Botox, it's about 10, 12 centimeters. So the medialization of the anterior rectus sheath along with the rectus needs to take place at least 5 to 6 centimeters on either side, which will not happen in a Reeves-Stopa repair. So that is when TAR comes in, which is the transversus abdominis release. So once we enter into the retrorectus space, we can't go beyond it. This is where the linea semilunaris is, which we discussed in the morning, and the neurovascular bundle traveling in between the internal oblique and the TA, the transversus abdominis. So we can't go beyond it. So what do we do here? So we hit this. If we want to go, we will be injuring the neurovascular bundle. So we obviously can't go beyond it. So what we do is we cut the posterior lamella of the internal oblique. So anterior lamella is going up. This is the posterior lamella. We cut the posterior lamella of the internal oblique and go into this TAR plane. So we've avoided injuring the neurovascular bundle and we've gone into the TAR plane. Once we get into the TAR plane, that's when we cut the transversus abdominis muscle. So you can see that's how it is cut. The mixture is passed just below it. So since we are doing an open TAR, so mixture is passed below it, then with a cautery or a bowie, we just cut this across. What we get is in the cranial portion, it is the muscular part. In the caudal portion, it is the aponeurotic part. So this is the cranial portion and you can see the muscle there. So we'll get into this plane just behind the transversus abdominis here, and we've cut here. So what we get now is just the peritoneum along with the transversalis fascia. So the TAR technique described is an extension of the Reeves-Stopa, so it was just an extension of the same. It allows significant posterior rectus fascia advancement with wide lateral dissection, and you can go right up to the psoas on both the sides. So avoids a subcutaneous tissue. So we've not made a subcutaneous flap. That just stays with the anterior rectus sheath, and therefore the SSIs and the SSOs, which is the surgical site occurrences, are a lot less and provides a large space for mesh as a sublay. So once we've gone here, we go behind here. So that's where that is what is being shown. We just go behind this so that we have only the peritoneum and the transversalis fascia right here. And we can keep going right up to the psoas. So we can keep going right up to the psoas. So this is a short video of which I've taken from the YouTube, and this is again by Philip Mysomes and another gentleman, I'm forgetting the name. So this is the midline which is opened, and so that's how. So what is being done here is that once that is open, that's the rectus muscle. This is the posterior rectus sheath, just a few millimeters below the midline. We make an incision on the posterior rectus sheath all the way down, and once we made that incision, that's the rectus muscle, and we are getting into the Reeve Stopa plane. So we get into the Reeve Stopa plane over here. So once we get into the Reeve Stopa plane, you can go right up to the neurovascular bundle, linea semilunaris. You see the neurovascular bundles over there, and once you see that, so all right, so now you see the neurovascular bundles. Once you see those neurovascular bundles, you need to give an incision just 5 millimeters medial to that. Just 5 millimeters. You see the sparking of the neurovascular bundles, and that is the posterior lamella of the internal oblique. You give an incision here, see the transversus abdominis, cut the transversus abdominis. So you give an incision, and like I said, in the cranial portion, you'll see the muscular part, which will become aponeurotic when you go lower down. You give an incision there, and that is the rectus muscle. That is that transversus abdominis muscle. You cut the transverse. This, of course, is a cadaveric dissection. Otherwise, you would need to do it with the cautery. And so divide the transversus abdominis TA muscle. Therefore, this procedure is known as transversus abdominis release. So you cut the transversus abdominis and go behind it or below it. So sometimes you can have some button holing over there. You need to be very careful once you are dividing the TA, and once you've done that, then you can go actually the peritoneum and the transversalis fascia, and you can go right up to the psoas. Once you've done that, then you would like to close the PRS. So we would generally, the suture recommended is 2O PDS. Suture is what we generally use to close the posterior rectus sheath. And then there is the placement of the mesh. So once you've closed the posterior rectus sheath, you would place a mesh. You can actually 30 into 30 very easily can come in, and sometimes if the abdomen is bigger, you actually need to put 30 into 30 in a home plate fashion. So once you've placed a large piece of mesh right here, then you close the anterior rectus sheath. Now anterior rectus sheath can be closed by non-absorbable or a delayed absorbable 1O suture, and then of course the skin needs to be closed. But we would always keep the drains in the retrorectus space, and these drains we would remove it only when the drainage is less than 30 ml. So once it's less than 30 ml is when we remove the drains. So the limits of dissection is superiorly diaphragm and central tendon, inferiorly pubic bone, space of Retzius medially, and the iliopsoas laterally. We can go up to gerotas, to the psoas actually. Closure of all peritoneal holes which may happen particularly when you are going behind the TA. Size of the mesh is 30 into 30. In larger abdomens, you actually need to keep two, one in a diamond shape and one in a square form. So that becomes a home plate fashion. Type of mesh is medium weight, macroporous, or a polypropylene mesh. A macroporous polypropylene mesh would be the choice of prosthesis which is kept. Mesh fixation can be done lower down in the Coopers. We are showing here by using a glue. So I would generally be using cyanoacrylate glue. It's not very expensive and works very well, but we would still fix the mesh both cranially and caudally, and then we would put the glue all around. And 2-0 running suture PDS to close the PRS. Anterior rectus sheath, I've already told you, sac should be preserved. We are going to have a talk on what we can do with the sac, because if we can if we can have the sac with us, we can actually prevent a TAR in most cases and get away with a reef stopper and using the sac. Retromuscular drain, I've already told you, check the peak airway pressure after closure of the anterior rectus sheath. Your anesthetist will check that. Do this surgery early in the morning so that the patient is kind of seen in the post-operative area, may not require an ICU. And so if the patient requires an ICU, obviously will be shifted. You would have taken the consent for the same. But like if you've given a Botox, you've done a good release, chances are less this patient will require an ICU. And then of course a skin closure. The pros of course are a good natural plane, allows for medialization, both posterior and anterior components. Closure of the defects is possible, avoids a subcutaneous flap creation, and therefore the SSOs are a lot less. But then can violate the abdominal wall, neurovascular bundle, easy to get into the wrong plane. One must know the anatomy very, very well, should have practiced it under a proctor before attempting these procedures. Large dead spaces are created, so you need to drain them well. It is technically challenging. It was the pioneer for this particular procedure is Dr. Yuri Novitsky, and he published his paper in 2016, and this was 428 consecutive TAR procedures, mean age of 58. So they were mostly in that segment of obviously complex hernias with a lot of comorbidities like diabetes, pulmonary function, and a patient having immunosuppression, large defects you can see. Surgical site events were about 18.7%, which is quite acceptable in this segment of patients. Again, patients with, so this was just a first year follow-up, but they did not have to remove any of the meshes. They had to trim a few, but they didn't have to remove. And even the recurrence rates were quite low, about 3.7%, which is quite acceptable, very acceptable if you look at these complex hernias. Loss of domain has already been discussed. I'm not going to go into it. This is one of our patients where we actually gave a Botox and then we did a TAR, and we'll just show you, not going to discuss any of this. It's already been done by Professor David. So this is the patient which after a Botox and a TAR, and this is how it looks like. This is post-operative. So you can see there's a loss of domain. You can always achieve these results, but then this has to be a combination of both Botox as well as doing a TAR for this patient. Thank you very much. I end with these interesting quotes by Warren.
Thank you, sir. We'll have question and answer sessions at the end. For our next talk on lab EDF, we would like to request Dr. Oscar.
So when we talk about the advantages of doing a ETEP-TAR, one is the physiological location. It works well with the principles of physics. The mesh is outside the abdominal cavity, so you're not worried too much about the problems. The boundaries, you have a very large space available for you. You can pretty much go to the vertebra on one side to the other side if we need. But usually the psoas would be good enough for major of the defects. Since it's uncoated mesh, it's usually cost effective. So we saw these images, just a brief run through again. So when we talk about the retrorectus spaces, you have to remember that they are two separate spaces and you have to do some maneuvers to combine them. So when we talk about a ETEP procedure which we do to kind of combine these I would enter into the left retrorectus space. Then after that, we would open up and dissect the space so that we can make our additional working ports on the left hand side. Then you incise the posterior rectus sheath on the left. You push the falciform ligament down, incise the posterior rectus sheath on the right, and then you create one large retrorectus space. So this is a bare mandatory requirement for you before you can start or think about doing a posterior component separation. So after this, if you need to do a posterior component separation, you will incise the posterior lamella of the internal oblique at this level, and then you will divide the TA muscle and then go in a plane between the fascia transversalis and the transversus abdominis. So it's not pre-peritoneal, it's actually pre-fascia transversalis. So when we talk about the muscle has to be bare. You should be seeing a lot of oozing from the muscle, only then you are in the right plane. If you have a nice fascia on top of the muscle, that means you are in a pre-peritoneal plane and the peritoneum is extremely thin in that area. So you can have a lot of buttonholes if you are not very careful, and even trying to repair them might be very cumbersome. As you take a bite again, it will tear, it will lead on to more bigger openings. So when we talk about the port position for a ETEP reef stopper and a TAR combined together, we have two options. So one, we enter through the left subcostal space, make two other working ports, do a crossover, and then we would make the fourth working port. So as Dr. David was saying, it makes it a little technically challenging for you to suture. So here we make the camera port in the left subcostal and use this port and this port for suturing. So you try to manipulate it slightly to make it into a more of a straight on suturing which you can make right from bottom up to the top. So just a brief clips. So first we insert the left subcostal port in a open fashion. Then you do a telescopic dissection in the left retrorectus space. And then you clean up all these fascia. So this white color structure you see on the top is the linea alba. We have to be careful that we don't injure the linea alba. And this is the posterior rectus sheath which is going and joining to form the linea alba. So this is the rectus muscle, this is the linea alba, and this is the posterior rectus sheath. So what you do is you stay around 5 millimeter away from the junction where the posterior rectus sheath goes and joins the linea alba, and you make a sharp cut, and this cut is done well above in the upper abdomen, at least 5 centimeters above the umbilicus, so that you have a nice thick falciform available to you. If you do it lower down, then you will enter directly into the abdominal wall and you will have a loss of pneumo. So that would make sure that the plane is not open like this and you will collapse on its own. So here just a simple monopolar cautery is good enough. Here we make sure that we incise only the posterior rectus sheath, we don't try to go too deep. And now we are pushing all this falciform fat down. And now you can see this is the linea alba on the top, and once you see this pinkish hue, that's called as the marshmallow sign. That means the rectus muscle is there behind your sheath. So there you incise it, and after incising it under vision, you just keep cutting the posterior rectus sheath on the right side as well. So now the right retrorectus space is open. So this is a purely preperitoneal plane in between, which is the falciform which acts as a bridge so that the pneumo is not lost. And this is the posterior rectus sheath which we are incising. So now you can see these are the neurovascular bundles which you see. So these are the, it's also called as the lamppost sign, and that is your limiting factor. You can't do any dissection beyond that. And here below you can see the rectus muscle. So in the upper abdomen you have a nice fleshy muscle. So now we are expanding the space. In this patient she had a divarication, and you can see how thinned out the peritoneum is. So here we are trying to be very patient and slow and try to preserve as much of the peritoneum as possible so that you can avoid a unnecessary posterior component separation if required. So this case you had only omentum and multiple small defects with a big divarication, but we were able to identify and do a good dissection. So you didn't have to do a posterior component separation in this particular patient. So once you go beyond the defect, you can see again we connect it into a purely preperitoneal plane, similar to how we would do it in a TEP repair. So this is a plane which you can easily open up, and it's quite familiar to all of us to go into this plane. So once you do this, the entire linea is dissected and exposed. So now all you have to do is just do the reconstruction of the linea and the closure of the opening in the posterior rectus sheath which we have created, the complex. And after that, you just place a large mesh, 20 by 15 centimeter or 25 by 15 centimeter, depending upon the body habitus. So this is the closure of the opening in the posterior rectus sheath complex which we have made to identify the content and reduce it under vision. So then we are just using a simple PDS suture in this case. You can also use a 20 V-lock 180. That is a good suture as well. But if you have multiple small defects and in a very thin peritoneum, it's always prudent to use a 30 PDS. So the more finer the thread, the better, because it won't increase the buttonholes which are present. So now once you ligate it, then you can see the entire opening is closed, and then you reconstruct the linea alba. So here we are starting from the lower abdomen. So this is kind of done in a Venetian blind kind of a technique. So here you can see a small defect. Beyond that, here also there was a defect. So there were, I think, 3 or 4 defects in this patient. So generally a lot of them are quite subtle. You don't identify them clinically, but once you do the dissection, you will be able to appreciate them very clearly. So here we are using a non-absorbable PBT suture, and whenever you're suturing on the roof, it's more comfortable and ergonomic to suture in a backhand kind of a fashion in laparoscopy. And once you're completed, you can see that is the reconstruction. The rectus muscle have been brought closer, and you can see both the recti are now brought closer, and you're not seeing a wide linea like how we saw it prior to our dissection. So this is the completed reconstruction images, and this is the final image of how it looks like. And once you're comfortable with this, then you can just place a large polypropylene mesh, and you don't need any fixation because it's a very close space. Once you desufflate, the mesh automatically gets anchored to the abdominal wall. So this is how a Reeves topa looks like. So if you're doing a TAR, the few modification and steps which we'll have to do is here you can see the right posterior rectus sheath is well away from the left. Even when you pull it, it doesn't come close. So what we do is we open up the Bogro space. So this is the inferior epigastric. We are opening up the Bogro space, similar to how we would do it in a inguinal hernia repair. This is an anatomy which is familiar to us. After that, now we are incising the posterior lamella of the internal oblique. So this is a bottoms up TAR. So you do the TAR from the bottom and you keep coming up towards the upper abdomen. And since it's more of an aponeurosis than a muscle, it's quite easy to rapidly open up the plane. And whenever you have dissected the plane, what we do is we use a blunt atraumatic instrument to go behind. We create and do a little bit of dissection and push the fascia transversalis and peritoneum away from our area of dissection. So that way, the area where you want to incise the fascia transversalis, the transversalis abdominis aponeurosis and the posterior lamella becomes very obvious. So you don't have to worry about injuring the peritoneal complex in the posterior aspect. So now you can see gradually as we are incising this complex of TA muscle and the posterior lamella of internal oblique, our incision is also coming more and more medial. So this is what I was telling to you earlier when I showed you the CT scan, that your dissection has to come more and more medial as you go to the upper abdomen. Because if you keep going in the same plane, then you will easily injure the diaphragm if you are not very careful. And now you can see the fleshy fibers of the transversus abdominis muscle is becoming more prominent. And this is the loose avascular plane which is available, which we have to do in a sharp fashion so that we stay in a true fascia transversalis plane. So that little bit of oozing which you see over there doesn't matter. So now you can see the bad transversus abdominis muscle. And whenever you're doing a TA, you should see the muscle on top and only fat on the bottom. If you see some muscle on the bottom, then that means you are not in the right plane and you'll have to recorrect your plane of dissection. So now we are carrying on with the dissection. The important part is not only the release. After release, you have to make sure that the peritoneum and the preperitoneal fat are all dissected well away from the muscle so that you can see how much of an overlap you can get. So this is after just a unilateral TAR. We have not done a bilateral TAR in this patient. You can see the amount of mobilization we were able to achieve. This is the divided portion of the TA muscle and this is the amount of dissection which we have done, and here we have gone up to the psoas in that area as well. So thank you very much for your patient listening. I'll be happy to take any questions you guys have.
Continue with the presentation. I'd like to invite our next speaker, Professor David Lomant, sir, on the topic Management Strategy for Lateral Ventral Hernia.
That was considered when it was described difficult. Why? Because we have a lot of bone structure that limit the dissection. So the ribs, the iliac crest, the lateral edge, the spine behind, the lateral edge of the rectus. So a lot of structure that limit the dissection, and so also the overlapping of the mesh. When we talk about posterior hernia that are still part of the lateral one, we talk about hernia that affect the lumbar area, like triangle of Greenfeld and Petit. So everything that is lateral to the lateral edge of the rectus up to the spine is considered a lateral ventral hernia. They are mostly primarily acquired, and we saw today many secondary hernia, mostly, in my experience, after orthopedic surgery. Why? Because they from the anterior spine, access to the spine for the cage, now they go laterally, and they go without the help of the surgeon. Before, I used to help the lateral. So they go retroperitoneal, and most of the time, they get infection, they get hernia recurrence. In terms of classification, we classify in 4 types, and L1 is a subcostal, L2 transverse, iliac, and lumbar. Each of them require a proper treatment because you can't do a subcostal at the same way you do a lumbar. So, in terms of presentation, I think CT scan is the best way. Of course, the physical examination, but CT scan is mandatory to understand where the hernia is. Can be a simple speech alien, can be a massive hernia with a bulb, a globus abdomen with the hernia on the lateral side. That easier can be a simple speech alien that are the most common, and we see more. Sometimes are together with the inguinal hernia. We can see hernia that are lateral between the rectus muscle at the lateral area, post appendectomy. We see hernia that are inframuscular. They go between the external oblique and the internal oblique, and they require also a kind of approach that is a little different. We see after liver transplant or subcostal incision, and we have hernia that are very lateral, for example. Like in this case, this is because of orthopedic approach, lateral orthopedic approach. So just to reinforce, the challenge to repair are the limitation because of the bone, the limit that create a difficulty to create an adequate dissection and overlapping, and also a proper fixation. So what are the options? Of course, options are open, laparoscopic, retromuscular, can be transabdominal, TAPP or PPOM, or can be a ETAP with opening of the space through TAR. So in our experience, we found we have about a series of about 50 cases considered lateral hernia, and we can see these are the specification. And we use an approach that vary. For simple hernia, that like a lateral hernia, we use a TAPP approach that is easy, comfortable. You can see the bulge here. The good thing sometimes you must understand that to repair, this is not a speech alien, but to repair a hernia like this is difficult to recognize because when you inflate the abdomen, the hernia distends and the bulge disappears. In most of the cases, the preperitoneal approach is much better. So to mark the hernia before the surgery is also important. So you go in the preperitoneal space that is a simple space, a vascular space. Access patient is a lateral decubitus until you identify the hernia defect. You keep in mind that you need to still use the same overlapping 5-6 centimeters all around the defect, and you still need to close the defect. You can close the defect by transfascial suture, the defect, or by intracorporeal suturing. Both are valid. In terms of outcome are similar. You can see the defect here. And once you close, you just put some mesh and glue. You can use some tacker because you can use then the tacker to close the defect, or use a suture to close the flap. Another approach is the same, is a lateral decubitus of the patient, and we use a E-tap approach. On the lateral edge, we identify, we go retromuscular. This is hernia, it's marked here, you can see. So you reduce the hernia. It's a good procedure also of fastest step to learn a retromuscular approach, because it gives you the confidence to work in a small space. You can see the hernia sac here. You can see the defect here. In this case, I think we use an intracorporeal suturing. You can reduce the pressure. To reduce the tension, you use an intracorporeal suture. You can use we use a V-lock. In this case, we use because it's a we use a non-absorbable. But you can use also long-term absorbable. In US, mostly today they use long-term, and then we use a pro-grip mesh in this case. It's a mesh that I think Radip show you with the difficult to handle because it gets stick, but in this way you can avoid the fixation and anything else. But anyway, it's a closed space, easy to do. In case in which you have a Spigelian hernia, you do a E-tap, a typical E-tap, like an extended TEP, just opening the arcuate line and going the retromuscular space. And then you place a big mesh, at least 12 by 17 or 15 by 17, to repair both. If even there is no inguinal hernia, we still clear the myopectineal orifice and we cover both hernia to avoid any problem. He was incarcerated about mostly omentum. We see quite a number of Spigelian lately. I don't know why. Maybe because we are a referral center, maybe. Another case is an interesting case. It's a lateral ventral hernia, inframuscular. You can see we use a robot. It's very easy with the robot. This is a patient in which they removed the iliac crest to reconstruct the mandible for cancer. They did in Belgium, beautiful operation. You can see the patient, no issue in chewing. So the patient, this is the future mandible. Patient got a hernia, got a primary repair, then recur, then was referred to us. For the lateral one, we do a robotic because we need to go behind the iliac crest. It's very difficult with laparoscopic to do. You can see the hernia here. We do a TAPP approach. Why? Because we can see in and out, so easier. So a lot of scar because of the two previous surgery. You can see the iliac crest is here, so you need to dissect very far behind. So difficult without articulation to go behind. This is the bone. I speed up a bit. You can see the bone here. So you need to dissect behind. But in this case, because of the defect was not very wide, but was quite long. So we use to help us in suturing and to reduce the tension, we use transfascial suture that we remove. So we use the transfascial suture to approximate the defect. We overrun. In this case, we did a double plication. And after that we remove the transfascial. Very difficult because you don't have a two edge. The other edge is attached to the muscle. So that's why we do application. In a couple of cases, in this case we also use a pro grip mesh. And even though it's a pro grip, we use in this case we use a titanium stapler fixed to the bone. We want to have zero recurrence. The lateral cutaneous genitofemoral nerve are behind and are proximally. So the bone is free by the nerve. So we use even though it's a pro grip, but we still use a metallic stapler. This is the patient after, I think, 1 or 2 years. We have a few more cases that with the same inframuscular, quite challenging case that we have done. In some cases, we did also. This is another case. It looks similar. We just speed up. And we just, in this case, also we do plication, and we use the same technique. What the guidelines suggest, there is not much evidence in terms of recommendation, grade C and D, so it means there is no evidence because the numbers are not that big. So that's why we have published our paper with a tailored approach for this case, and you can see in different cases what we do. In L1, we tend to do an IPOM plus, L1 is a subcostal. For transverse, we do, if there is primary non-complex, yes, we do ETAP, otherwise we can do a TAPP or IPOM plus. The other challenge are L4, in which we use almost a tape or TAPP approach. I think Ashwin was showing with the suprapubic approach and fixation to like inguinal hernia. So in conclusion, they are very challenging to repair. We don't have guideline or anything. Open surgery for hernia larger than 12 centimeter is to suggest. In this case, we use always a sandwich technique. We do with two mesh, one absorbable, long-term absorbable, and synthetic mesh on the superficial aspect. And if we do laparoscopic, if it adheres to lateral, we use robotic, but laparoscopic approach is a very easy way to do. Thank you so much.
Listening lots of talk on different types, techniques of hernia repair. Now we all know the mesh infection is really a nightmare for any surgeons. So to talk on about the mesh infection, I would like to invite Dr. Ashwin.
Be wondering why we need a discussion, right? If it's a florid mesh infection with a lot of pus and the mesh floating around in it, I don't think we need a talk. All of us know that we have to drain the infection pus and also remove the mesh along with the fixation devices. Otherwise, the wound is never going to heal. Or if it's a very superficial infection, just at the skin and subcutaneous level, but not at the fascia or in a deep organ space, again, not much of debate there. We know what to do. We just have to control the infection, drain it, and make sure that the wound granulates in a secondary intention. But what about in between these two scenarios? Probably that is what I'll try to address and touch upon in my talk. So we will see how things are changing. So whenever we get a patient, I think the three factors which we have to definitely optimize, there's no question about it. One is obesity. So we know that we have good enough evidence to say that any patient with a BMI more than 34 is definitely going to have a lot more surgical site occurrences and wound problems. So it is ideal that we reduce the BMI by at least 10% of their body weight before you embark upon any surgery. The second factor is smoking. Smoking cessation for at least 4 weeks is definitely a mandatory requirement. If you don't do it, then again a lot of wound problems, wound breakdown, even a recurrence is a possibility in those subset of patients. The third one is diabetes mellitus. So any HbA1c above 7.5 is not ideal. So you should try to get the sugars under control and a HbA1c value of less than 7.5. If you don't correct these problems and you straight away go ahead with surgery, then automatically you increase the chance of a mesh infection for this patient. And remember that mesh infection is not only going to showcase itself within the first few months or first year. Sometimes it can present itself as long as after 11-12 years after the primary surgery. So you're never safe. So when we talk about the classification of surgical site infections as per CDC, it can either be superficial, which is the skin and subcutaneous tissue, or deep, which is basically the rectus sheath, your muscle and the fascia, or a organ or a body space, which is basically the intraperitoneal space which you have. So why is this important for us? As I told you, superficial and body space, probably you know what to do. But it's only the deep area which we are going to talk about and touch upon in this talk. So there are more things which we should be familiar if we are thinking in terms of a salvage. So what are those things? So say a patient has a small control collection. The mesh doesn't seem to be floating around. It seems to be integrated. And this infection is not a full-blown floral sepsis. It's more localized. Then we have to look at these factors to identify if it is a conducive patient where we can think of a mesh salvage or it is not possible at all. So what are the factors? One, if you have a polypropylene mesh, the chance of salvage is much higher. Whereas if you have a polyester mesh or a mesh like a EPTFE, there is almost no chance for salvage. So rather you just have to go in and remove the mesh. Otherwise there's no point giving him medication for 6-7 months or a year and then saying that infection is not settled. That doesn't make any logical sense at all. The second one is the porosity. So if we have something like a dual mesh or if you have a microporous mesh, then that will not let your body's immune system, the mast cells, to go into it and fight the infection. So again, there is no possibility of salvage in a microporous mesh. So if it's a macroporous mesh, then we can think about salvage in those patients. If the patient has an MRSA infection, then again probably it's like a relative contraindication. A lot of the times it might not work and you will have to remove the mesh. If the bacteria is adherent to the mesh and you don't have a very conducive filament material available to us, again salvage will not be possible in these subset of patients. If a biofilm has already formed also, unless you go and do some form of debridement close to the mesh, you will not be able to salvage the meshes in these patients. So like I told you, microporous meshes definitely you can't salvage. So if you have seen in the operative notes that it's a microporous mesh, better to go in early and remove it. If it's an EPTFE, you can't salvage it, you have to remove it. Polyester, again salvaging is very difficult because it's a multifilament mesh, more prone to infection, you will have to remove it. Composite meshes are a combination of both and they always tend to be a little microporous than the uncoated meshes. Again we will have to remove it. Heavyweight meshes generally are microporous and there's a lot of foreign body material. So these meshes also to salvage is a very big challenge. You will have to remove the mesh. So when you think about a salvage of a mesh, you should also understand about the planes. If it's an intraperitoneal mesh, almost no possibility of salvaging the mesh. Whereas if it's an onlay mesh or a sublay mesh, then you still have a possibility of thinking about salvage. Because here the mesh is not directly in contact with the bowel, it is outside the peritoneal cavity. So if you have a very conducive picture of a proline mesh, macroporous, and the position of the mesh also is very conducive, we can still do a open debridement and you can do a negative pressure wound therapy to promote more granulation tissue to grow over the mesh, provided the mesh has already integrated and the sepsis is controlled. The severity of infection is the key. If it's a localized sepsis, then yes, you can definitely salvage. Whereas if it's a full-blown sepsis, unstable patient and an open kind of an infection, then there is no role of salvage at all. So this is a very nice algorithm on how to manage if you have a wound infection. So we have a exposed mesh or a open wound. If you don't have anything like that, you do an image. You see how much of a fluid collection is there. If you have a collection, you definitely have to drain it, either surgically or through a percutaneous drainage. If there is no fluid collection, then we have to think about the materials, and based on the favorable materials and outcomes, you can still observe and with conservative management. If it's not favorable, then we'll have to go for a dedicated therapy in those kind of patients and see if it's working. If it's working and if it's resolving, no problem. If not, we will have to subject them for again further surgical management. So if you have an exposed mesh and an open wound, but the mesh is integrated, it's not floating, then we can think about taking a culture, ruling out atypical mycobacteria, MRSA and other infections, and based on that you can start a empirical antibiotic therapy and local wound care like debridements and also a negative pressure wound therapy. And how it resolves, based on that you can do a partial mesh excision, or if it's not resolving, then we'll have to do a complete mesh excision in these patients. So thank you very much for your patient listening.
Making this complex situation very simple and explaining it in a very simple way. For next talk, I would like to provide some data on the topic is peritoneal fat mesh hernioplasty.
Gentlemen, today I am going to present the peritoneal flap hernioplasty for complex ventral hernia. So this is my team. So we know the principle of ventral hernia is reapproximation of fascia to achieve primary closure in a tension-free manner to recreate a normal functional abdominal wall anatomy. But if the patient with large abdominal wall hernia, like patient with near about 10 centimeter defect, intracutaneous fistula, or exposed mesh, multiple recurrence, they are complex patients, so they need something different. We have heard talk of component separation, either anterior or posterior, and these days we need some form of component separation in this kind of complex ventral hernia patient. So if we see this equation, a small amount of reduction in radius, like we need to close this muscle, and a small amount of reduction in radius lead to large amount of reduction in the volume of abdominal cavity, causing the loss of increase intra-abdominal pressure. So if we see the hernia repair, and it's just like analogy of sleeping bag and sac concept, we need to push sleeping bag inside the sac. So in difficult patient, what we can do is we can make the sleeping bag smaller by pre-op strategy like weight loss. And this bowel preparation, we don't do most of the time because it increases the wound infection. Sometimes organ resection like momentum of bowel may be required, but again it will add complexity in this kind of patients. So weight loss is definitely required to reduce the content. Another concept is we can make sleeping bag bigger, like we have heard talk from Professor Lomanto, like for Botox and PPP. So Botox is the common thing we do here in our department, but it's not without, definitely it has cost, compliance, cumbersome, and PPP definitely has some complication. Intra strategy, what we have is component separation, peritoneal flap. Fasciotones is the new things coming in the market in a very big way, but it's still in the research phase. Another is bridging repair in this complex patient. So if we see this paper by Indian group, Dr. Sarfraz, in a short-term and mid-term result of open TAR, near about 72 patients, his bridging repair is 10%. So we see in the one of my previous presentation, more the bridging repair chances of recurrence is high, and time of recurrence is again very early in this kind of the patient. If we see this study from the Michael Rosen group, he's running an abdominal wall surgical unit. So it's a big hernia. I mean, the mean defect size is 26 centimeter. Here, if we see the recurrence rate, it's near about 50%. There is some, I mean, it's a ventral hernia recurrence inventory. So they have added the patient who had, I mean, they have told telephonic conversation, and if patient says I have bulge, so they added in this group. So it's near about 50% in the bridging term. So if we see this equation given by Michael Christie, so this is abdominal circumference 360 degree, and this is the abdominal aorta, and if we calculate this angle and divide by a whole abdominal circumference, and if it's more than 0.21, patient need some form of component separation. But if we compare our patient, Asian patient and European or American patient, our circumference is less. So even in smaller defect, we need some form of component separation. So component separation again is not without any complication. I mean, definitely there is it comes with the expense of lateral wall integrity, segmental nerve is risk of injury, and sometimes, I mean, with the TAR posterior component separation, sometimes the anterior fascia doesn't come in opposition, leading, I mean, this patient, it's our patient, we done the TAR, but after 3 weeks, this mesh was exposed. So again, sometimes it's anterior closure is difficult, even with TAR. So with long history, we are building bridges. So there are 2 bridges very close to us. And so the peritoneal flap is one of the method of bridging repair. Is first put in the paper by Lazaro de Silva. So if you see this picture, he has 3 overlapping layers. The central aponeurotic layer closer, and the mesh is transected and is closed in the 2 layers. So 2 peritoneal layer, 1 central aponeurotic layer, but it's without mesh. Then next, it was popularized by Edinburgh group. So if we can see this slide, here is the peritoneum of this big sac. It's quite thick. It's quite thick. It's not like a flimsy peritoneum. So it's a hernia sac. It's quite thick. And if we see the normal anatomy, what we see in our books is the linea. Here we see a quite thick linea, and anterior rectus sheath also quite thick, posterior rectus sheath also quite thick. Let's see this CT scan. Can we appreciate the linea? It's quite thin here. So again, this peritoneal flap hernioplasty was popularized again by this Edinburgh group, by Andrew and Bruce Today group. So what is this? It's a sac transected into the 2 parts. Then Reeves stopa plane is created, and mesh is posterior layer is closed. Then mesh is put in the Reeves stopa plane, and this is one flap goes posterior, one came anterior. Then this is the mesh is sandwiched between these 2. So the advantage of this is it preserves. I mean, we are not dissecting laterally, so there is no weakness, too much weakness. It increases the abdominal domain and capable of reconstructing even the midline and transverse hernia. Larger the hernia, larger will be the sac, and larger will be the flap for closure. So in the study group of Edinburgh group, they have near about 251 patients, and the mean defect size was 2.5 to up to 25 centimeter. If you see the recurrence rate, it's just 2.8. So what the proposal they gave is, I mean, what the theory they gave is, we need an intact abdominal wall cylinder to have a good abdominal wall function. So most of our core abdominal wall function depend upon the lateral oblique muscle rather than rectus. So even there is a gap in, gap in the muscle. Until unless we have this intact cylinder, our abdominal wall function will be adequate. Like if you see this lateral hernia, so here the midline is intact, but abdominal wall function is not as good as it should be. So there are a lot of critics about the peritoneum and the mesh. So this group from the India, Mata Purkar, is I think from Safdarjung Hospital. So they done the peritoneal flap hernioplasty in 1990s. What they do again, transection, and the mesh is put in the inlay fashion, and the two peritoneal flap. So there are a lot of critics about that. They have criticized about the peritoneal flap. So what they have done after 9 years, they done the study in the dog. So what they do in the 7 dog, they cut the lateral rectus sheath of one side. Let's see, right side rectus sheath was divided, and the peritoneum of the left side is excised and implanted on the right side. After 6 months, they kill the dog and see the peritoneum which was implanted on the right side, and what they found, it was transformed into the aponeurosis. So what they propose is peritoneum as a stem cell, is a pluripotent cell, has capacity to transform into the aponeurosis. That is the reason given for less recurrence in this patient. Again, even with this study has shown the adding tar. So Andrew group has just reef cystopa. Most of the patients have reef cystopa. In this group from Sarfaraz, he added tar also, what we call tar plus, to the peritoneal flap. Doing surgery for at least 18 or 20 centimeter plus hernia. So what they found is it avoid a sudden increase in the intra-abdominal pressure, because we are creating a large abdomen, and it decrease the cardiopulmonary embarrassment post-operatively, or even putting the patient into the ICU. Because if we see this data from the US, the respiratory failure rate after the abdominal wall reconstruction is near about 10% patient had incidence of post-operative respiratory failure, and near about 7% of the patient required ICU care. Definitely is as advantage of less bowel adhesion, fistulation. Even in the morbid obese patient, we can find a good peritoneal flap. But the limitation of this study is, long-term data is not there. Not too many studies are there. So there are 3 studies which I found, and if you see the recurrence, one is from Edinburgh, one is from Sweden, and this is from India. And if we see the recurrence is just less than 3%. So in our experience, we have done near about 15 patients of this peritoneal flap hernioplasty. So this is gentleman of near about 14 centimeter defect, and after putting a Botox in this patient, we excised the skin scar, and then this subcutaneous plane is dissected till the anterior rectus sheath. Then peritoneum is divided after doing adzolysis. So in this video we can see the sac is attached here with the not too much skin is excised. So we are keeping the sac with the skin till the in. So I will fast forward. Then one side, this is flap to ARS is created. That means we are putting a incision on the posterior rectus sheath. If you can see in the second video, here the incision in the posterior rectus sheath, retrorectus plane is created, and this flap is attached to anterior rectus sheath. So this video we can see this is a peritoneal flap, and here the incision will be given. Incision is given on the anterior rectus sheath. So this flap will go to posterior. So again here the retrorectus space is created, and this is the flap, peritoneal flap attached to posterior rectus sheath. So this we can see this flap, this retrorectus space posterior rectus sheath, and this is flap attached to posterior rectus sheath. And this is anterior flap. So mesh is after that posterior rectus sheath and flap is closed. Mesh is big mesh is placed, and then anterior rectus sheath and flap is closed with anterior rectus sheath of opposite side. So this is again a next patient. This is a flap attached to incision on the posterior rectus sheath on the right side. This is incision on the anterior rectus sheath on the left side. So this is creating the posterior flap. Then posterior wall closure with the, this is a peritoneal hernia sac. This is the part of flap. The mesh is placed and the anterior rectus sheath is closed with the flap. So as much as we can close the anterior rectus sheath together, it will be fine. When there is a gap, we can put the hernia sac. So these are a few of our patients. So we have done here about 15 patients with the mean defect of 13 centimeter, and our surgical site infection rate was 20%, and length of hospital stay was near about 8.5 days with zero recurrence. One, we have bulge on the CT scan, but it was not recurrent. So in conclusion, ladies and gentlemen, I can say that we can see that it's a useful procedure for large incisional hernia, better than bridging repair, less bulge, it provides more strength, reduce the chance of mesh exposure and sepsis, alternative to Botox and PPP, and technique is easy and accessible to every surgeon because this complex procedure like TAR, anterior component separation, definitely needs some learning curve to master it, and there is definitely a chance of associated nerve injury with those sort of procedure, and definitely increase the abdominal domain, reduce the post-operative intra-abdominal hypertension, and it reduces the need of elective ventilation and useful in cases of loss of domain. Thank you.
Thank you all the speakers. I think we invite questions and comments from the floor, please. I think if no more questions, I have one question. So how do you assess the efficacy of Botox after injections? Do you get CT scan done frequently, or do you just assess clinical?
To me or to Prof?
Of defect before proceeding for abdominal wall reconstructions after Botox or progressive pneumoperitoneum?
So usually we have about at least 4 to 6 centimeter reduction.
Okay.
Sometimes we have some patients more. It depends on the status of the muscle. If the muscle are very well, very trophic, very strong, you have more relaxation. If you have very small, very thin muscle, then the relaxation is much less. That's what we know.
Okay. Thanks.
So some data suggests generally 2 to 3 weeks is maximum you should be waiting. That's one. In progressive pneumoperitoneum, you would actually measure the circumference. If the circumference on consecutive 2 or 3 days remains the same, then that's the maximum advantage you can get with PPP, and then the patient should be advised a surgical procedure.
Okay. Sir, and do you have any scenario when you have come forward that when you try to close the abdominal wall rectus sheath after component separations, you are not able to close it? So what to do at that time? So if the PQ pressure rises, if PQ pressure rises and you are not able to close, so do you bridge the mesh in between?
So as Dr. Randeep in one of his lecture just mentioned that when we do reconstruction, we keep the this hernia sac intact till the end of the surgery. So we don't divide We don't cut and take it out, excise it. So even after doing the component separation, even if we can, that is the question. If you cannot close, then you can use that hernia flap as a bridging repair for the posterior. So most of the time posterior will not be a problem, because posterior, if you do component separation, tar, you can go till the this lateral, till quadratus lumborum you can go, and you can create the plane. But most of the time anterior will be the problem. So answer to that, this question is better to keep the hernia sac till the end of the surgery. You may require at some point of the time.
So I think your peritoneal this flap can also be used, and that can also be used. I think is it safe to bridge the gap with the mesh after the peritoneum flap?
No, it's just like a sandwich. So one peritoneum is, one layer low down and one anterior layer. The mesh is sandwich between, just like a recto rectus repair.
Yeah. So we have a question.
I have a question for Dr. Aswini, sir. For the defect closure, so I've been doing IPOM Plus. I'm doing transfacial closure. So what do you advise? Transfacial is better, or closure the defect with Proline is better, sir?
So intracorporeal sutures are definitely better. If it's a very small hernia, transfacial is still acceptable. But if it's a hernia, say more than 2 centimeters, I think transfacial will not be very precise. You will be going in an inclined angle, so we won't be able to judge exactly how much of the tissue we are taking. And the more amount of tissue we take, the tension on the tissue also would be a lot. So in the post-operative period, it has a tendency to tear off. So if it tears off, then that will also be a result of recurrence or mesh migration in the later post-operative period. So intracorporeal is more precise, so that would be the best way to do it.
So I've been doing for the last 5 years, but I have no any recurrences. But I think this, as you rightly said, this intracorporeal is more better, no, sir?
Yeah. So in ventral hernias, the more we wait, the recurrences will pop. There's no question of no recurrence. All our patients will get recurrence. How quickly or how late is the question. So we are trying to push it as much further as possible, so that probably I'll retire, or at least they won't blame me for the recurrence. So that's the only intention.
Thank you, sir. Thank you.
I think if there are no more questions, we'll end the sessions. Thank you all our speakers. Thank you very much.
Dr. Vishnu Kandel. To honor Professor Rohit Prasad Yadav. I request Dr. Suresh Prasad Shah to honor Professor Narendra Pandit, and Dr. Ghanshyam. Suresh. Thank you.
Reminder again, please don't miss the opportunity of Bali trip. So please register from the registration desk for tomorrow's quiz. Now we'll have a break of 10 minutes for as a tea break. We'll be shortly back after 10 minutes. Thank you.
And so retraction of spleen can be difficult. So to be safe, what you should do is actually put a gauze or a sponge inside on top of the spleen and then give pressure to retract. Okay, as you see the gauze there. So with slow and steady dissection there, you'll be able to get the margins closer and then closure of the defect similar to what you just saw. So this is a hernia which will be repaired exactly the same way how we've done a Mogagni, but the access is challenging in these patients. So after we've done that, we are going to use a mesh even in this place. the part of the mesh that is going to go inferior there onto the diaphragm, you cannot use any fixation. Your fixation will mostly happen on the anterior abdominal wall. So what we do in these patients, this part of the mesh that goes inferiorly, we will use some form of glue. You can use a tissile glue, you can use cyanoacrylate, and few sutures on the top. And again, moment you have few points of fixation, you have glue there. Moment you get the gas out with the spleen that would press onto the mesh out there, it will not move. So this is the glue. This is the cyanoacrylate glue that we are using to fix the lower margin of the mesh. So that's a hernia, bocadalic hernia. And this is a traumatic hernia. Now this is a hernia which has happened. This was a young lady who had this hernia, who had this injury, had history of rib fractures, and she was symptomatic with large amount of contents lying inside. There you see fundus of the stomach going in. The hiatus was right here. So this was a hernia which was right next to the esophageal hiatus. The right margin of the hernia was formed by the left crus of diaphragm. So that's the lung. Because this was a traumatic one, there was no pleura as such. So you can see the lung there. So the same steps, you keep mobilizing. And that's what you're seeing is the hiatus. You see the esophagus there. That is the left crus of diaphragm which you're exposing. And you will get this fundus of stomach completely mobilized, get it down, and that's the defect. So then you pull the pleura, you get the margins of the pleura, whatever you can see. Use absorbable Vicryl there to close the pleura. And then with non-absorbable sutures, you close this defect. This is an old video, and why you can make out this old video? Because we do not have a V-lock suture in there. We don't have V-lock. We did not have V-lock available at that point of time. So these were non-absorbable interrupted sutures that we had taken, and this was reinforced by another kind of composite mesh. That's a tie mesh. So in fact, we use, whenever we have to use some form of safe mesh close to the esophagus, close to the diaphragm, this is also a good mesh to use because it's extremely light. And recommendations are for intraperitoneal use. So we do use this mesh even in the esophageal hiatus for larger hiatus hernias. So what have we learned with diaphragmatic hernias? They may mimic eventuation of diaphragm at times. Acquired traumatic diaphragmatic hernias are the most common ones. Large diaphragmatic hernias require intensive peri-op care, intensive care in the post-op, and mesh may be needed to help these closure of these hernia defects. So thank you very much. That's all about these hernias.
Please continue. You're the next speaker.
It is not an indication of surgery, only in a symptomatic patient. Patients who are recurrent and coming back with respiratory symptoms because of the reflux are indications of surgery. Barrett's esophagus, young patients who do respond to medical therapy but they relapse moment you stop the therapy will need surgical management. What are the contraindications? These are mostly like other laparoscopic procedures, patients unfit for GA, patient with coagulopathy, morbid obesity. Morbid obesity, rather than doing a anti-reflux procedure or a hiatal hernia repair, you should be doing a bariatric procedure for these patients. And a surgical procedure like Roux-en-Y gastric bypass is the best procedure not only for addressing weight loss but also addressing GERD and patients with esophageal motility disorders. We need all standard equipments. I mean, that is available to us when we are doing gallbladders and hernias. You do not need anything extra, probably other than a liver retractor. As you get more experience, you do not even need a bougie for this. Ultrasonic device is available to mostly everyone in big centers today. So you hardly need any additional equipment to do these procedures. So that's a bougie. Nowadays, what is available to everyone, especially general surgeons, is the bougies that we use in bariatric surgery, but of course they are all available in the market. So these steps of surgery, we always prefer to do these surgeries in a modified lithotomy position. We take a steep reverse Trendelenburg position. Surgeon stands between the legs. You have the camera person onto the right of the patient and the first and the second assistant on the other side. So the advantage of this position, though it can be done in supine position, is that there is no crowding between the surgeon and the assistants. So this is how we take the position and the OT layout. Port positions. This is the telescopic port, which could be a 5 mm or a 10 mm depending on the choice of the surgeon. So that's supraumbilical, a little higher. Right-sided mid-clavicular line, a 5 mm port, which is a left-hand working port for the surgeon. And that's the 12 mm port on the left side of the patient as the right hand. And anterior axillary line, that is for your assistant to retract the fundus of the stomach. So these are the steps of surgery, and on which I'll show you video for each. That is, the step 1 is to retract the left lobe of liver, reduction of contents, division of short gastric vessels, mobilization of the esophagus, hiatal repair or approximation, and followed by a 360-degree fundoplication, that is the Nissen fundoplication. So that's an Athasson's liver retractor that we use. So moment you go inside, you look at the broad anatomy, left lobe, and that's the fundus of the stomach, that's the spleen, that's the omentum. So that's what you see on your initial diagnostic step. The next step is to divide the short gastric vessels. So the upper 3 to 4 or 5 vessels, you can be liberal with that because it is of no consequence. So we will divide the above 4 to 5 short gastric vessels, get into the lesser sac there. You find a large short gastric vessel. You can be, especially we try and use a clip onto the first vessel on top, because if it bleeds, it retracts, it can be challenging. So that's the division of the short gastric vessels. Now this is our learning which has actually made us a little better hiatal hernia surgeon after we started doing bariatric surgeries. That is an extremely good mobilization and exposure of left crus of diaphragm. I remember before we started doing sleeves and gastric bypasses, we never used to expose the left crus starting right on top and seeing it join onto the right side right below. But this is what we do now, that we expose the entire left crus of diaphragm. That makes your approximation easier, as well as if you have a good mobilization, patients will have less dysphagia in the post-op. Now onto the right side, exposure of the right crus, that's the pars flaccida. You divide the pars flaccida, you look at the right crus of diaphragm, and that's the white line which you follow right from below, taking it to the top. When you reach close to the diaphragm, that's the phrenoesophageal membrane that you will divide, and you will keep moving on to the left side and identify the left crus on the opposite side. So this is a complete mobilization on top of the esophagus, and then you start creating a window. So what we do out here when we start creating a window behind the esophagus is, we don't try and look for the vagi, the posterior vagus. We just lift up the entire mass of tissue behind the esophagus, get a window there, put a sling, and then we are sure that your vagus is safe there. So that's the esophagus, and the moment you have a sling there, your control becomes so much better, your exposure becomes so much better, and then you get a good length of intra-abdominal esophagus. So we want at least 4 to 5 centimeters of esophagus intra-abdominally. So that's the esophagus, the right crust, the left crust. So now this is a hiatus, which is actually not a very big hiatus. It's become big enough by dissection. So these are the kind of hiatus in which just a suture repair actually is good, because you see the pillars, they're nice, muscular, thick, so the sutures are going to hold. Suture of choice, again, any non-absorbable, you can use ethibond, you can use proline, so that's a ethibond that we are using. So a couple of sutures, we do not take the closure right till the top, because you have to leave certain amount of space for the food bolus to come down, otherwise these patients will have dysphagia. So that is the amount of closure we will do, and the next step would be a wrap. So you get the fundus of the stomach onto the other side. Now if you have mobilized your fundus well by division of short gastrics, you can see it comes up easily, and you can also do the shoe shine maneuver. So that's the shoe shine maneuver, which you can only do once you have mobilized the esophagus well. So once that mobilization has been done, the last is to fix the mesh in position. You will need at least 3 sutures to give you a 4 to 5 centimeter wrap on top of the esophagus. One of the bites of your sutures should be coming through the esophagus to stabilize the wrap onto the esophagus. So one suture through the esophagus is good enough. 2 other gastrogastric sutures, and that's what completes the procedure. And you should be able to put at least 1 instrument behind the wrap, below the wrap, to make sure that it's a floppy wrap. So crural repair, as we talked about, should always be a posterior repair, because if you try and do it anterior, the distance is larger, the sutures are going to cut through, so repair should always be a posterior repair. Complications, what we can see which can happen is bleeding, esophageal injury, pleural tear. So pleural injury, especially in large hiatus hernias or paraesophageal hernias, is very common, so you have to be careful about that, make sure you don't miss it. And post-op, you have to counsel your patients of the possibility of dysphagia. So all these patients will have some element of dysphagia, which will stay for 2 to 3 weeks period, but they have to understand that this is normal. So you have to let them know. Gas bloat is not there if you have divided the short gastrics. Nausea, vomiting, these are rare things, and if you've used a mesh, complications of a mesh, this is more theoretical rather than what we usually see. So when doing a Nissen fundoplication, we have to make sure you do a floppy wrap. There are 2 schools of thoughts. There are surgeons still who do not mobilize the fundus, but we do in order to do a floppy wrap. Use a bougie. If you are not sure about how tight wrap you're making, use a bougie at least initial part of your career. It does have high rates of patient satisfaction, provided you have worked up your patients well. You do a surgery in a patient where it's not indicated, you will always have an unhappy patient. So you need to work up your patients well preoperatively. As we had discussed, intra-abdominal esophageal length should be 3 to 4 centimeters to have good results. And a complete wrap is something which does minimize reflux, but most studies, there is very little to choose between a 360 degree or a 270 degree toupee wrap. Especially patients who are elderly, who are old, who will have some element of gastric atony or esophageal dysmotility, it's better to do a partial wrap than a complete wrap. And yes, this is what we said. Thank you very much.
Thank you, Professor Manish.
Okay, I would like to welcome Dr. Sachin Paudel for his expert talk on parastomal hernia, update on repair and prevention.
I'll be talking about parastomal hernia, update on repair and prevention. So, basically I'm going to talk mainly based on the European Society guidelines that had been published recently, 2019. So according to the disclaimer is that if you go through the guidelines, it's just the evidence that's surrounding parastomal hernia is very limited. So you don't have a lot of paper, like compared to inguinal hernia, it's like next to none. Even compared to ventral hernia, there are very limited papers. So there are only very few recommendations that actually come, and I'm going to show you some videos. So the incidence, the reported incidence according to literature is 30% in 12 months, 40% by 20 years, and 50% in higher if you wait for longer. So according to the literature, half of the patient you have the stoma, they are going to have the parastomal hernia. In practice, do you actually have that much? I was in a colorectal surgery institute. I don't think so, but it's higher than commonly accepted by the colorectal surgeons. That was my experience. So colostomy is it has more incidence of parastomal hernia compared to loop colostomy or loop ileostomy. And diagnosis, there is no gold standard that is recommended by the guideline. Physical examination in supine and erect position with valvus maneuver is one way, and CT ultrasound is in uncertain cases is recommended by in the guideline. But I think as I talked in the imaging, it is a complex hernia. So I think personally I think CT scan is a must. So for watchful waiting, so a lot of especially colorectal surgeons, they tend to watch the non-symptomatic patients with high because the patients are non-symptomatic, and as I said, these parastomal hernia repairs, they have the high recurrence rate until currently. So they think a lot of patients are being watchful waiting, but there is no evidence currently to support this. But saying that, there is also no evidence that says that this cannot be done. The studies are not yet, so we cannot make any recommendations. So for prevention, there is a school of thought that says extraperitoneal approach of making a stoma is better than in transperitoneal route. Meta-analysis shows that extraperitoneal is better, but it's all limited because of the retrospective nature of and then there are very, very limited literature. So, and also pararectus location and transrectus location, there is no difference in the reported outcome. So in the guideline, these two, and there is no recommendation yet. But probably if we have the more cases, more studies going on, the tendency is that the extraperitoneal extraperitoneal creation of stoma tends to have a less parastomal hernia. And also ideal size of fascial aperture. So this is, I think this is a sort of it's a sort of common sense statement. So as small as possible, that you can have the bowel out without it causing any ischemia. So, and one thing that really have the evidence is really pouring in is on the prophylactic mesh. Like I said, in 5 years, the literature says 50% will have hernia. So it is, so the studies, there are few studies that have gone, like randomized controlled trial that has gone, and it is recommended to use prophylactic synthetic non-observable mesh while constructing an elective permanent end colostomy to reduce the parastomal hernia rate, but no recommendation in the loop ileostomy. But I'm not sure, in Japan, I don't know any surgeons that currently practices this. In Nepal or Japan, Dr. Lomanto is not here. So, but okay, the guidelines say this, evidence is coming here, but probably it is due to but the colorectal surgeons are not currently doing it, and it's not commonly practiced in the eastern part, like the Asia, as far as I know. And types of repair. So there's a suture repair. This is the simplest technique. You just close the defect. This comes with it's a high recurrence rate, very small Probably you can do it if it's an emergency case, you do it, but according to the guideline, it's not not recommended. Relocation, it's one of the option. You just relocate and close the hernia location and relocate it in another. It has also similar some recurrence rate, but like the data is, again, as I said, limited to make a conclusive evidence. Open mesh repair and laparoscopic repair is there, and the comparative studies are also very limited, and so currently there is no recommendation on which repair is better in case of recurrence, in case of in regards to the recurrence rate or other morbidity like wound recurrence, like mesh infection and so on. Like my personal favor, I personally favor laparoscopic repair because I want the wound to be as far as from the stoma as possible. So, and that's one of the reason. But evidence-wise, no recommendation yet. So for laparoscopic repair, what type of options do we have? We have one options, like one of the simplest is use a keyhole mesh, but it has a very high recurrence rate of like around 30%, and it is not recommended. So it has, and I think a lot of hernia experts can agree on this. Another is Sugar-Baker repair. Its reported recurrence rate is around 10 to 12%, and there is another repair like a sandwich repair that combines the keyhole mesh repair with Sugar-Baker. It's also, the recurrence rate reported is 7.6%, so around 10, or roughly around 10%, but it uses two mesh, and like you have to use a lot of tuckers, and there is only limited data, only few case series published on this. So it's up to your choice if you feel that like two meshes are necessary. But for me, I think like Sugar-Baker repair is more than enough, like based on the current data. And new techniques like using E-tape repairs, in the recto-rectus space, like Pauli's repair is being also advanced, but it has just recently started, so we still need data, follow-up data, long-term follow-up data of these repairs. So currently there is no, except like the keyhole is not recommended. For other laparoscopic repairs, it does not say which repair is better than other. So this is one of my cases. Like most of my parastomal hernia that comes to me are like these, like a huge bulge causing discomfort. So when it is small, like when the patient is not complaining, they don't tend to come to you to get repaired. So like as I said, my preferred technique is Sugar-Baker, especially for these LAs. This is how I do it. I put a big cotton there, and I cover it with 2 or 3 layers of sterile opsite, yes, opsite. So because opsite and like okay. I give a 15 millimeter incision. I get to the rectus fascia. I put it in a cocker, and I go with a 5 millimeter optical trocar, and then I insufflate. This is how I go with the optical trocar, so that from the fascia, not from the skin, because most of the okay. So I am like okay. So what I have done here. Okay, I go from the fascia with the 5 millimeter trocar, and then I put another 5 millimeter trocar here. I remove the 5 millimeter trocar and change this to the 15 millimeter trocar, and then I use that 5 millimeter trocar here. And first is you need to dissect the adhesions, and like you need to take all the adhesions, and most of the time you have you will have the central also. And like you say, like for the bleedings, You can, if it's just the momentum, you can just use the, I'm using the bipolar device here. And mostly I'm using the monopolar. And this is the amount of bowel that got stuck inside the defect. Here's defect. And then this is one of the challenging part, like you need to do the idealysis and you need to recognize, firstly, sometimes it's very difficult to recognize which is the stoma bowel. So you need to preserve the stoma, you need to dissect between the bowel that is forming the stoma and the bowel stuck to it. So like Dr. David said and Dr. Oswin also said, like you need to use cold thermy without, and then you measure the defect. And one thing you do with, like we are using the size 1 V-lock, and because of the huge defect, I don't want to lift the bulge. So I try to plicate as much as the sac as possible. So this mostly you have to do it by the one hand. Both hands cannot, and then you use another hand to support you, like my another hand is going there. So I'm plicating as much as sac as possible. So you're just closing the defect, you will still sometimes you will still get the bulge and the seroma. And then you and then after you reduce, like we go for two or three times to make sure that this is closed properly. And this is preparing the sugar baker mesh. Like you know, so like they used to sell the sugar baker mesh for sugar baker technique, but currently this is not available in Japan. I don't know if it's available in India or something. So we use this composites mix from the commonly available. I measure and prepare the. I trim it to the size that I want, and then I also make the flap, the flap that is supposed to go on top of the bowel. So I put it on the, so adhesive material is, so that on the bowel I don't want the mesh to directly, I want the adhesive material there. So I overturn it and I suture it there, preparing the sugar baker mesh for the sugar baker style. So generally I put it 6 centimeter flap, but this time I'm putting 8 centimeter because it was the double stoma. So and the end, like I have here I have on the end that is supposed to go there, I have 2 transfascial suture that I need to pull it up. One here, and like total 5 transfascial suture. And then I roll it. And I just tie it here, so that I don't want the both flaps to come out, as I want one flap to come out together. So for this I insert it, and first I put the cranial transfascial suture out. You go through with the endoclose, and also then now it is, as I roll the mesh, so the handling becomes much more easier. So I had a trouble here, so I went just with the end close, I passed. So if you remove the one suture, only one of the flap that is on the other side will get released. So, and now you wrap the stoma around this, and so that you have the 2 sutures, so you pull one each. Now you have wrapped the stoma and then lateralized the stoma. So after you've done this, like you can get your tuckers out, and you start tucking in the zigzag fashion around the, first you go around the stoma, and then you tuck the the half that is further, and then you just remove these two strings, then this flaps comes out, and this is similar to the IPOM plus repair. Okay, and I also have a video for E-tape poly repair. This is not done by, this is done by one of, for a small hernia, this is done by one of my friends in another hospital. So I'll just give a brief this is also one of the options, but like I think it's still very controversial, very difficult operation. So it's similar. You make a retrorector space near the stoma, near the hernia sac. You open it up, and then you open it up. And the way you do it, open it up, and you you need to create this retrorector space all around the stoma. So that is, I think, the difficult part. And also you need to, because of the location, you need to do the tar. Always the tar on the unilateral tar is always required. And after creating the space, first you close the hernia defect, and then you lateralize the stoma to the abdominal wall, where one suture is enough, and then you close the posterior layer. And after you close the posterior layer, you put a adhesive barrier sheet around the stoma to protect the stoma, the bowel. And then here, he's using and then here he is inserting the, this is a pro-grip mesh in the, for a small hernias, this may be one option, but for large hernias, I think it will be too time consuming. So, like I said, the hernias, I get the big ones. For me, like the lap sugar baker is still good, but in future, maybe we can seeing more of these repairs. Thank you.
Presentation on parastomal hernia. Now I would like to request Professor David Lomenko presentation on management of diastasis in ventral hernias. Thank you.
Otherwise, we become a plastic surgeon. It's not our territory of competence. But the plastic surgeon come to us, and we do a lot of combined procedure today, especially we do rectus hernia and they do mini abdominoplasty. We still prefer a posterior repair. The plastic surgeon, when I was a resident, the plastic surgeon was very advanced. Used to do a small incision suprapubic, and then he has a tunnel instrument, an S retractor. He put a telescope inside, the cystoscope, I remember, I used to do with a long needle holder application, anterior application. So when today they come and talk about new procedure Scola, I say this is a very old procedure that 40 years ago already the people do. So nothing new, because they do anterior, but the anterior is an inversion, so the results are not that great. So what we used to do, because we copy from our closure, transfascial suture, this is a schematic and draw is on our book. How we do, I'm sure most of you do the same, nothing new. We do an approximation for simple reason. We want to close the muscle, not completely. We want to also reduce the pain. More you tighten the knot, more pain you may have. So you need to just approximate the muscle. That's why we call LARDA, laparoscopy approximation. We don't close any muscle. There are different techniques. I think Paranivelu published his Venetian blind technique. Today, with the help of a V-lock suture, we do intracorporeal suture. Even though I can tell you today when I do robotic, I try to use more Prolene because I can slide the suture, especially for long suture. It is much more helpful and give me more room, more space to pull up the suture compared to the V-lock suture. And transfacial or combined, as I showed you before, sometimes combined for larger access is very useful. So we all follow the same rules of restoring the linea alba. We have done about 45, 60 cases, and we are talking about robotic because I showed the robotic, but look, what we do usually, you can see the diastasis. Is a large diastasis. There is umbilical hernia concomitant. Before we used to patch. Today what we do, we do just a primary suture. We overlap with mesh just to reinforce the abdominal wall and to reduce the risk of a relapse. But we really don't know. Probably primary caution may be enough. In this case, we use a robot, but we do most of the time we do laparoscopically. So we just use the overlap of mesh. In this case, we use the same technique as a normal IPOM. So we can also do a retromuscular repair, like in these cases. We can do, for example, a PPOM. So we reduce the hernia. This is just to why we did the robot. It was the early learning curve of the robot. So we need to have some simple case to start before we go on the ETEP or TAR. So we need to do some simple case to acquire confidence. That's why we start to do some of these cases. So we just do a flap. We open the abdomen. We open the retromuscular space. We should have done also a IPOM in this case. And we close the very large defect, about 4 or 5 centimeters. What we learn from this technique that we'll never do. Why? Because suturing the muscle without a fascia is a bit difficult, and you may tear the muscle. Most of these patients, the muscles are very weak because they don't exercise, the muscles are very poor quality. So if you tend to pull too much, you tend to cut through the suture. But results are very good. You can see in this patient, and most are young patients.
Great day listening to your amazing presentations all day since morning. Now for the last presentation of today's session, may I invite Professor Sunil Sharma Thakal for his presentation on how to do a fabulous job with limited resources, the role of mentorship and friendship in surgeon's career. Professor Sunil Sharma Thakal is currently is the president of the SAR Surgical Care Society and immediate past president of Society of Surgeons of Nepal. Please welcome Professor Sunil Sharma. Sir, thank you.
Take too much of your time. First of all, I'd like to thank the audience for staying back so long. It's been a really tiring day, and now you guys are inundated with hernia left, right, and center. Secondly, I would like to thank Rakesh and Dr. Shah for inviting me here. And before I start, I just want to make an announcement that we've finally made our dates clear. Please put the dates on your calendar. It's 21st, 22nd, and 23rd of November, where we're going to have the SARC Surgical Care Society conference as well as our national conference in Pokhara, hopefully. So please fix your dates, and we'll try to make it a big conference, and please join us. Now, I have a few disclosures. I have been doing mentorship for the last 30 years, but I'm not going to be presenting you any of my own data. They asked me to talk on something completely different from what's been going on so far. So I thought I will highlight a few things to make it interesting for you, so that now that you are all armed with your knowledge of hernia and you want to go and practice your hernia, and your question to is, Sir, Tora, हामीसँग त यो पनि छैन ऊ पनि छैन, limited resources, where do I go? And then you said, I wish I could have trained with David Lamento. Now raise your hands who want to train with David Lamento. Everybody in this hall wants to train with David Lamento. Is that possible? So the mentorship question comes that, can you actually do that? Before I start, this is something that I always believe in, is Sarve Bhavantu Sukhina, Sarve Santu Nirbhaya, Sarve Bhadrani Pashyantu, Ma Kasi Dukha Bhagavate, Om Shanti, Om Shanti, Om Shanti. In other words, if you cannot do good, do not do harm. Okay? Okay? This is not moving.
Click on the...
Click on which one? This one. We all want to do good. We all want to be David Lamentos. We all want to be the big guys. Manish Banjal. We want to be Palanivelu. But the most important thing as surgeons we got to understand is patient safety. No matter what we do, patient must be our priority. We are not gods. And gods are going to come after you, and they were there before you. There are enough surgeons who think they are gods. What's the difference between God and surgeon? God never thought he was a surgeon. Right, so but we all surgeons think we are gods, and we got to try and get over that. So patient safety is very important, and whenever you're doing a new procedure, remember that person on the table is not a case, is a patient. Somebody's dad, mom, son, father-in-law, brother-in-law, uncle, the divorced wife, somebody you hate, but still a person. Right, know your limitations, your knowledge, your skills. Enhance your skills. You want to be the best guy in town, you enhance your skills. To tell you the fact, some of the best surgeons in the world, or the best sportsmen, the best dancers, the best musicians have all come from small towns. Yes, Nepal, Dharan, Kathmandu is a small town. You can be the best guy in town as long as you enhance your skills. And the way to enhance your skill is to keep practicing, discipline, dedication, and perseverance. I know my talk's a bit different. Why do I bring this slide? Shushruta taught this to us 6,000 years before, and we forget. Shushruta used to give pumpkins to his disciples. He used to give them bagan. He used to give them a potato. He used to give them a clay mud. And say, okay, now drain an abscess. Make a nose flap. So he never allowed his disciples to go directly into a patient before they went through the practice of going through skills and the mentorship or apprenticeship as we know it today. And some of us call it the Holstadian training, but mentorship is slightly different from the Holstadian training. So when it comes to patient safety, what is most important? Of course, patient safety is important, and gone are those days where you see one, do one, teach one, especially from the YouTube these days. We go into the YouTube, we look at one surgery and we think we can do it. But what is more important is get yourself accredited. Go for a course. Go for visual learnings. There are so many Zoom meetings, but most importantly, there's the AMASI, there's the IAGS, there is the ELSA course. Get yourself accredited. Tell the world that yes, you've got yourself the training to be a hernia surgeon. You've got the accreditation. Then you can slowly move ahead. And of course, there is mentorship. Right. Know about your limitations. Is your knowledge lacking? Review yourself. If your knowledge is lacking, it's easy. You can just build it up. The most difficult is your skill. You will tell me now, sir, the skill गर्ने ठाउँमै छैन. Of course there is. Get a mirror, get a pair of old laparoscopic instruments, look at the mirror and start practicing in your room. That is your simulation. That is the cheap simulation. Learn suturing. Without suturing, you will not move ahead in laparoscopic surgery. Of course, if you want to excel, you must go beyond your comfort zone. You're scared to swim, you're never going to go to the sea. Unless you come out of your comfort zone, you're not going to excel. And there are ways to achieve it. We'll discuss that later. Now you guys must be surprised, what am I doing this? KP Oli, our Prime Minister, opposed this map. Do any of you recognize this map? This is Akhanda Bharat, where you can say Bhutan and Nepal is within it. In fact, even Tibet is. Narendra Modi didn't have the guts to put Tibet because he knew Xi would be very angry, but he did put India and Bhutan within it. Sorry, Nepal and Bhutan within it. The reason I show you this is, within this realm of this map lies the two biggest and the oldest universities of the world. One is called Nalanda and the other is Takshashila. Takshashila lies in Pakistan today and Nalanda is in Patna, which is being restored. For the information of my Japanese colleague, by his assassinated Prime Minister, Shinzo was helping India to restore Nalanda. Why do I bring Nalanda and Takshashila? Because of this man. All of you recognize this man, Chanakya. But how do the Americans recognize him? Do any of us in our part of the world study about Chanakya? No, we don't. What about the Americans? Yes, they do. The American Marines and the American Armed Force have a 32-hour credit and they read what is known as the Kautalya Niti. In Kautalya Niti in Arthashastra and Yuddha Shastra. So Kautalya Niti is studied in America, yet we in the East who have access to Chanakya, Kautalya, have ignored him. Am I here to teach you about his Artha Niti or his Yuddha Niti? No. This is Chanakya Niti as to how to self-improve and go ahead. These next three slides of mine are the three most important slides if you want to make it big with limited resources. And the number one thing he has put is self-discipline. Okay? He has emphasized the importance of self-discipline as a foundation for success. He has believed that self-discipline enables individuals to control their impulses. I'm not going to read through all my slides. The second, which we all doctors tend to forget as we mature in our career, is continuous learning. The third most thing is thinking out of the box or strategic thinking. If you want to be a leader, you've got to start thinking out of the box. He emphasized strategic thinking. You must think, what is David Lamento going to be doing for this case? What difference is he going to be doing? Or what is your colleague next door, what he or she is going to be doing? You've got to start thinking like your enemy, as he says, so that you do better. Persistence and perseverance. Of course, way back, now Chanakya is almost 1500 years ahead. I think more than that. And he taught about networking. We've got to start being members of ELSA, Hernia Society, Surgical Society, IAGS, so many foundations. Be a member of the foundation. Get information. Today is a day of information. And you have access to it through the internet. So if you want to work in a limited resources, get that information, start your networking. You will find a mentor who will now train you through telemedicine. You don't need to have a local mentor. Most importantly is ethical conduct. Ethical conduct is very important. And lastly, which we in this part of the world tend to forget, is time management. Our symposium today is almost 1.5 hours late. Time management is very, very, very important if you want to be successful. Right, so the next topic that was given to me was mentorship. How helpful is it? Well, we've all been trained in the Hallstadian way of training, and many of us still in this part of the world, especially in India and Nepal, still follow the Hallstadian mentorship training, and we're still going through it. But if you look at in the West, there's a big change. Everything is structured, training is structured. You may not be with one trainer for a long time. As I said, not everybody can be trained with David. But yes, you can actually train with David because there are so many ways to train with him. And that I'm going to show you how. So there are the hierarchical, the usual colleague. Self-mentoring is one of the most new and modern ways of doing it. Is there an ideal mentor? Where does the word mentor come from? It comes from the Greek mythological character called Mentor, who was asked by Odysseus to train his son. But if you look at the standard the dictionary now, the Standing Committee of Postgraduate Medical Dental Education in the United Kingdom has described mentoring as a process whereby an experienced, highly regarded, empathetic person, which can be difficult these days, guides another individual or mentee. So there were a lot of articles I researched, and this was one I found which looked at mentorship in surgical training, a systemic review. They looked at almost 125 articles and pointed out 36, and what was their conclusions, that there are quite a few barriers to mentorship. And the themes that they discussed was, first of all, when one of us goes abroad to train as a mentor, there's a huge cultural difference. And the white gentleman, they may not understand what you're actually trying to say, and your reason of you being an introvert, being quiet, not questioning him. It's your cultural differences. Generational differences. Somebody old like me, 60, may not understand what a 22-year-old wants. Or gender differences. We don't have too many women who are mentors or trainees. And I think we will not be able to understand a lady's point of view, no matter how much we say we do and how mature we are. Scarcity of qualified mentors, and the most important, I also agree as a mentor, I'm not being able to commit, is time commitment issues. This is the biggest. Again, another article from the role models and mentors in surgery, and their conclusion was there's a clear evidence that it supports, however, you need time for this, and it's a lifelong experience. Something closer to us, this was from Africa, implementing surgical mentorship in a resource-constrained context, and their conclusion was it definitely helps. Not the mentorship as it is known in our system, where it's a all-stadium process, but the mentorship that I'm going to mention to you in a while. This was the latest article, which was, I think, made the most sense. It had also looked at quite a few reviews, and they brought it down to around 17 articles, and this was just published in 2023. So I think this made the most sense, so I'm going to present that. And what have they mentioned is the ideal mentor, David Lamento, a mature senior person with the authority in the field. He's got no biased opinions, a teacher by nature, wants to teach for no benefit, ensures that the training is student-centered. The disadvantage is when you go to his place, it's short period. There's a long waiting period. Everybody from the world wants to come and work with him. So he's got maybe 4, 5, 6 years of waiting. And sometimes continuity is not possible, and it can be less personal. Or maybe you'll never ever get to go to this kind of person. So there are 6 traits that this article says which makes a good mentor is commitment to the role of mentoring, a sense of empathy, skills in providing instructional support, versatility in different interpersonal contexts, a model life in continuous learning, and the ability to communicate with optimism to the learner. Okay? So again, this article says that there are 10 points that as a mentor or a mentee that you got to look into before you start your mentorship. I'm not going to go into the details, but there are 4 bad mentors. Now, this is especially in our part of the world. Well, I wouldn't say only our part of the world. It happens everywhere in the world because we humans are the same. Because especially with us surgeons, what sits on our head the most? Our egos. So it's the uncommitted phony. They are not involved in teaching and easily distracted from their duties. The perfectionist turned tyrant. I'm sure that's something very familiar to most of you here. The individual leads by example. Initially seems like a great guy, but in the end, do not be fooled. He always expects him to be in the center. The insecure, egocentric. And of course, the grudger. He's always grudging all the time, and he's worried that you're going to overtake him one day. But then you may have the local senior mentor, a senior colleague who's an expert in the field, vast experience. He may not be, he may just be an expert. He may not be the authority there, but there is going to be a long mentorship with him. It's going to be a personalized mentorship program, and selection may be much simpler. The disadvantage is there's going to be a personal bias. If you worked with him or he knows you personally, he may not like you, just your face. So maybe you've got to do some plastic surgery before you go to him. Learning may be a plateau due to the mentor's own or his own capabilities. A difficult relationship, not only to form but to maintain throughout the length of a surgical residency. Medical education is a challenging journey, and this path is only more difficult without compassionate and caring leaders and help guide the way. There are numerous different styles of mentorship, which I've already mentioned. So in the importance of quality surgical mentorship cannot be overstated, and surgical residency programs should be made a definite and continuous effort to provide this essential service for the residents. Thank you very much. I'm willing to answer any questions.
Is very integral in the surgical education.
Thank you.
So any questions now?
Any questions? I think you're all tired. Got a CT scan and found out this is a traumatic diaphragm. For 5 years he suffered so much. Eventually it was cured. So that's what I wanted to share. So that's the end of the session. I'd like to thank all the great speakers. Always, enjoying talking, them listening, and above all, I'd like to thank, like Professor Sunil said, the audience. We had so much patience and been sitting, all the residents and other delegates. Thank you all. Have a wonderful evening. Just a kid when I was a medical doctor.
Thank you, sir. I request Dr. Suresh Shah, sir, to come forward and do the honor to Professor Mahesh Khakurel, sir. And Rakesh, please join to Suresh Shah, sir. I request Dr. Ashish Poon to come forward and receive the memento.
It's now time to deepen our conversation with panel discussion. So, without any further ado, I'd like to request Professor Randeep Wadavansar.
Okay, so this is the first case scenario. 46 years old male. There was history of laparotomy with a midline incision for an ileal perforation 5 years back. RA was done. 3 months after the laparotomy, he started noticing a bulge along the lower part of the incisional line. History of SAIO twice, managed conservatively. On examination, there was a incisional hernia which was at M4 at W1. M4 would be, and W1 would be about 4 centimeters. Okay, anything W1 is still 4 centimeters, W2 is 4 to 10 centimeters. Scissor. So if you can see, what I am doing here is pulling the bowel. In fact, pulling the mesentery or gently holding the bowel and just pulling it down or pulling it with the sheath and ensuring going a layer above. So layer above means I'm taking down the peritoneum at places, and you'll just notice I'm going even a layer above and taking down the PRS. So taking down the PRS, taking down the peritoneum. So I'm doing it only and only with the cold scissors. It can cause enterotomies. So iatrogenic enterotomies are known to happen. So go a layer above, and then the only other trick which you need to do is, once you've taken down a part of the PRS, use a wide mesh, use a bigger mesh to cover that area as well. So you need to cover that area as well. So this is taking down, and you'll notice at times that we've gone, in fact, taken down the PRS as well, and the rectus muscle is exposed. But when I'm using the mesh, or so that mesh needs to be wide enough to ensure that it's covering the defect. So you can see the rectus muscle right there. So the mesh has to cover this area as well. And then always inspect the bowel. So always inspect the bowel, see that the bowel is, you've not caused an enterotomy. Move your forceps, graspers from one end to the other end. And of course, you see that there is a layer above the bowel, which is actually the peritoneum, transversalis fascia, posterior rectus sheath. We are not going to go through how we close these defects. We've already seen that. And then of course a mesh needs to be kept, and it's covering that area of the or exposed rectus muscle as well. Okay, so we go to the next case scenario. So I'll move on because Rakesh has told me that you need to cut down on the number of procedures that you're showing. Okay, so this is again interesting. This was a donor nephrectomy 6 months back. Notice swellings along the incision line 2 months after the surgery. So L1, L2, W2 hernia. So this is something that Professor David showed, that you can always do a tap. You can actually do an E-tap, and I'm showing you completely different. You can also do an IPOM plus. So this is a large hernia, it's a W2, it's almost a 6 centimeters, and I have a follow-up of this patient for nearly 2.5 years now. And okay, so this was the defect. So there are multiple options. Manish may also say that you can always do a hybrid here. Hybrid is an option, there's always an incision, you can open that, close the defect and then place a large mesh. Now this was a big defect. Like I said, it was almost 6 centimeters, but it was L1, it was a little lower down. So in a donor hepatectomy, they would just go a little lower down. So you put in a large mesh. So it can be done. It's not as if IPOM is a contraindication per se. Yes, you can always do a tap. You can also do an E-tap, but this is rather simple. And close the defect here. And once we had closed this defect, in 2 layers, we placed a huge composite mesh, a coated mesh, and fixed it completely. And like I said, we have a follow-up of nearly 2.5 years now. This patient is doing all right. So even in these hernias, an IPOM plus can be done, which is simple to do. You can always do a hybrid as well. Just give a small incision, close it, and then place a mesh. But the mesh has to be big enough, like it was discussed, 4 times the size of the defect. So that's why I said 25 centimeters. So the mesh has to be big because the defect size was 6 centimeters. So 4 times 24, so 25 centimeters mesh. Okay, so this is an interesting case. 55 years old male, underwent a lap IPOM plus 6 months back, BMI 34, persistent, he had 2 discharging sinuses, and again this was discussed as somebody had quoted about atypical mycobacterium, that it generally presents about 3 weeks, 4 weeks after the surgery. That's what happened, 2 discharging sinuses. So when the patient had multiple drainage procedures and atypical mycobacteria, everything was given, the patient continued to have discharges. CT was done, CT showed collection over there, and the discharges were persistent, they were chronic, 6 months. So that's when the patient came to me. I would have asked this question, what needs to be done? But what I did was, I went in, took out the sinuses, took out that mesh, and of course just suture closed it. And after suture closure, of course, told the patient to lose weight. The patient came back to me with this. Okay, so this is how the patient came back to me. What would you do next? So since there's paucity of time, I'll just go ahead. We advise this patient 2 things. One, of course, first and foremost, lose weight. He was still about 32 BMI. We told him to lose weight and then come back to us. And we had planned, once he loses weight, at least reaches a BMI less than 30, then we'll go for Botox and then go for a TAR procedure. That's what we did. He came back 29 BMI. He took about 6 months, came back with a 29 BMI. We gave him Botox and then we did a TAR procedure for him. So that was his CT just prior to taking him up for the procedure for a TAR. And that was his TAR. Bilateral TAR is what we did. And this is just post-surgery. So this was something where a patient had a sinus because of an IPOM which was done. Obviously the instruments would have been infected. The patient had atypical mycobacterium. We excised the sinus. We suture closed it. Then we asked the patient came back, asked the patient to lose weight, gave him Botox and then did a TAR, which is definitive. Patient is doing all right. So it took almost a year and a half before this patient got this finally from an IPOM plus which was done earlier. Another interesting case, just look at the CT and just look at the right side. So this patient had a renal cell carcinoma, had a robotic surgery for that, but you'll see, so the hernia, so this is where the hernia happened, where actually the urologist had given the incision to take out the specimen. So that's where the hernia happened, and the patient also had an umbilical hernia. And so we discussed what can be done for this patient, and finally we'll just show you what we did. So we again reduce the content. This is the umbilical part. That's the, so we measured the defect, we added both of them together and we measured, it was again 25. So it was roughly about 17-18 centimeters, and we knew it required a huge mesh. We did an IPOM plus on this. So this was of course done robotically, which was discussed in the morning, and we could actually send this patient home next day morning. So this patient was sent home next day morning after an IPOM plus. Tab block of course was given. Both the defects were closed. This was closed, and then patient had a little divarication of the recti. So we closed the umbilicus. We closed the umbilicus as well as completed the divarication of the recti. And what we've done is we've stopped using transfacial sutures. If you see, I've only taken one thread out. This is just to hold the mesh in that place. I do not take transfacial anymore. We've seen the pain happens. We've seen hernias coming out of these transfacial sutures. So just one suture, just to ensure the mesh is placed. And then of course, robotically, which was discussed in the morning, just take a V-lock suture. You can do it laparoscopic also. That is what Dr. Sunil just mentioned. Learn your endo-suturing. It is extremely important. You can cut down on a lot of costs. So you can, of course I'm doing it robotically, but you can always do it by sutures, and this is a barbed. So see the, can you see that huge hernia? So that's a huge hernia which is there. Have a look at the lateral view right there. See that hernia? This is how it looked. Now invariably, and we, of course, this patient had loss of domain. Again, this is a patient where we gave the patient Botox. We generally are giving about 300 units. Earlier, of course, it was recommended 500. We generally give 300 units. Waited for about 2 to 3 weeks. Went ahead, and we actually got away with doing just a reef stopa. It required cosmetic because of all that skin over there, and we could get away with just doing a reef stopa repair. This is how it looked, and it didn't require a TAR. So that means it didn't require a transversus abdominis release or cutting the transversus abdominis muscle, just a reef stopa, just because this patient was told to lose a bit of weight and then the Botox. So I'll just wrap it up with this. We won't go through any more. Thank you very much.
Won't be finished in one day. So there is a chance that we'll have to come back again. So that is the first thing I always counsel when I talk to the patients and their family. The first thing, because you don't want mesh infection, like, because like after seeing all these things, so, and like if there is a possibility of mesh injury, if you have a bowel injury, enterectomy, like, and then you need to be prepared the patient for that. So if there is a bowel injury, you finish with that analysis, you come back after a few days and you can finish the surgery later, right? So I have few procedures. Okay, this is that we collected. This is not my case. Okay, this is with the lower abdominal surgery. So he is surgeon is dissecting in the inguinal area. So, and this is the laparoscopic ultrasonic scissors. So the surgeons don't want to injure the bowels, but it is dense and he does not know what he's cutting. So do you realize what he just cut? Huh?
Cannot make out anything.
Yes, but the reason it's a bowel and it's an inguinal region. So he's dissecting the triangle of doom, and slowly the bleeding has started, and now he realized, and this is the gauze there. And we're going to take it. There's a big hole there. Can you see that? Is also opening also like, okay, this is, yeah, opening is a very good option, but by the time you open, like the pneumoperitoneum is like, this is a venous bleeding. The pneumoperitoneum is so helping push the bleeding, like manage the bleeding, and they are also applying the pressure on the thigh area. So, huh? This is not my case. But like, okay, this also says like what Dr. Sunil said. You have to have, so this surgeons, they had, okay, they were confident with their laparoscopic suturing skill. And they repaired it, but they didn't repair the hernia, because after like going through all this, says, okay, do no harm. So they just said, okay, we'll do it later. The blood loss was this like 300 or 400 ml. So not for everybody, but this can happen, right? Because there are even literature reviews like an inguinal hernia, like after especially robotic assisted, like there is a trend, like with all the, like everybody is going to lab for the laparoscopic hernia repair, and then like, especially in Japan and like in the world, a lot of people, they do a laparoscopic hernia repair because they don't know how to do open repair. So in post-prostatectomy, like it can be done. It can be done. It's and it can be done safely also. But it's always very easy to do it open repair. So, and if why increase the chances of complications? So, and then
can I make a point here?
Yeah.
So in this, what needs to be done at this moment is, even though you could be experienced in
Yes.
suturing, have more ports in place.
Yes.
They need to have additional ports and ensure that everything's in order, and then you can go ahead and suture this.
So this one was presented in a sort of closed meeting, and then we had a chance to talk, and then we discussed what could have been done and everything. And the reason they said, okay, we can go with laparoscopic repairs, like when they started, like they putting the pressure on the thigh, and like that controlled the bleeding somewhat, and like they could see the and the triangulation was there, and like, so okay, let's first do, because this
external iliac
artery. So putting a gauze, like opening up at that point is a very good option, but don't open it until you have a control. If you have at least you have a pressure point, because if it's just bleeding and you leave it like that and just stop waiting, like 10-15 minutes is times to get there, you'll have a huge bleeding. So if you open, you need to have some sort of pressurized point. One assistant needs to be continuously compressing that before you open it. Right? So, and then, but like this, having said this, and like there was a case report in the ELSA journal also that it can be repaired laparoscopically, but like they sort of made a big deal out of it, saying, okay, because it can be repaired laparoscopically, I think it was justifiable. We wrote a letter to editor regarding this article. So having said this, if by saying that you have skills to repair it laparoscopically does not give you a right to injure external iliac vein. especially in an inguinal hernia or a simple case. If it's a big hernia, big like cancer case, like that's a different thing. So another, I have a slides from Dr. David, like about the enteroptomy. Okay. So, like this has been repeated multiple times. Okay. So analysis, be on the safe side. Don't go to bowel. If you don't know what you are cutting, just leave it until you are showing sub-dissection. And the video is not working. Okay, so we'll just go. It was working? I cannot play the media. Almost all my dissection, and I'm trying to close the defect. Also VLOC scissor. You know VLOC needles are very big ones, like a very thick one. And like I have trouble trying to get it out. And I lost my needle inside the muscle. Yeah, and it's a huge, and then, yeah. And we're getting ready, so this time we just palpated, and then we saw the distance from this is from the ports, how far it is that we had lost, and then we made a small open incision, and then we tried to, but it's pretty difficult to find the needle. So while the CM was getting ready, fortunately we found before we needed a CM, and so this was the case I had. So be ready, unexpected things can happen. So this is my message: be vigilant about the complication that may occur and try to avoid it, and counsel your patients so that and be ready. And if complications occur, try and limit the damage to the minimum. Thank you.
And 20 moderators and all others are our delegates. So I would like to invite all of you in the gala dinner in the Nirvana Country Club. See you at 7:15.
फर्की आयो अपने प्यारो बाटो समझेर Well, ladies and gentlemen, as we have now enjoyed some moments of entertainment, it's now time to express gratitude.
And for that, may we please request Dr. Suresh Prasad Saha, Additional Professor of Department of Surgery, to come on the stage and express vote of thanks.
all long way away from Singapore, and he has a very big contribution to uplift the surgical department here in BPKHS. And similarly, big round of applause for Professor David Lomento. We have Professor Manish Paisal and Professor Randeep from India, Delhi Max, and they have a big contribution to our department to uplift the surgical procedures and surgical fraternity in our department. So a big round of applause to Professor Randeep and Professor Manish Paisal from India Max. Similarly, a professor from Mahesh Cockrell, the retired professor but an eminent surgeon, who has taught many surgeons in BPKHS, and he has taught the laparoscopic surgery, laparoscopic cholecystectomy at BPKHS. So many thanks to Professor Mahesh Cockrell for his contribution to BPKHS. Similarly, special thanks to Professor Shibata from Japan and Professor Sami Paudel from Japan. They are a big way to come to Dharan. It's difficult time in winter season. The planes are not working. The travel is difficult. Despite of that, they tried to come here, and they have contributed a lot to our surgical fraternity. And similarly, Professor Sunil Kumar Sharma from Medicity Hospital, he has a big contribution to uplift the department, to have a big contribution in our surgical fraternity. And in last 3 months back, he conducted a very big conference of Surgical Society of Nepal, and big round of applause to Professor Sunil Kumar Sharma. Similarly, we have Professors Romeo Kansakar, Professor Rupesh Mukhia, Professor Mukundra Joshi, and many big distinguished professors from Kathmandu and all over the parts of Nepal. Big round of applause to all those. Similarly, we have the program would not be possible without the support from different pharmaceuticals. So for that, we have different pharmaceuticals have contributed to conduct this program, and we have Olympus company, they have supported, we have Merrill company, those have supported for this program, and SQ Lab, and with this DJPL, and Prime Pharmaceuticals, this and so many other companies, those have supported, I have list, but if anyone missing, please forgive me. This DKM company, and so many other Divine companies, so many other companies. Along with me to distribute this certificate. Please come.
Vital Sutures, Olympus,
Similarly, next we have Quest Pharmaceuticals,
Please come here to support us. Dr. Abhijit, please come.
similarly DKM Pharmaceuticals,
Dr. Bhavani Khanal also please come forward.
Torrent Pharmaceuticals, Max Pharmaceuticals,
Your exceptional efforts and ongoing contributions to the development of minimally invasive surgery in Nepal. Over the last decade, your dedication towards advancing minimally invasive surgery, particularly minimally invasive hernia surgery, has greatly impacted the surgical society in Nepal. Your expertise and knowledge have been instrumental in improving surgical techniques and outcomes, ultimately benefiting countless patients in our country. Your commitment to sharing your expertise through workshops, seminars, and training programs have been invaluable in enhancing the skills and knowledge of Nepalese surgeons. Your willingness to invest your time and energy in guiding and mentoring young surgeons has nurtured a new generation of skilled professionals who continue to make a difference in the field of surgery.
Things, especially teaching hernia surgery. So here from Nepal Hernia Society, I would like to invite Ganesh. Where is Ganesh? Ganesh. So I would like to honor him as a honorary member of our Nepal Hernia Society.
Ladies and gentlemen, we gathered to celebrate the remarkable achievements of a truly great surgeon, our esteemed professor, Professor Mahesh Khakurel. In realm of medicine, Professor Khakurel has not only mastered the delicate art of surgery, but has elevated it to an extraordinary level. Professor Khakurel is not merely a practitioner of medicine, he is an architect of hope and healing. With a steady hand and a compensated heart, he has dedicated his career to pushing the boundaries of medical excellence. Countless lives have been touched and transformed under his skillful care. It is with great pleasure and honor that Nepal Hernia Society confers upon Professor Mahesh Khakurel a Lifetime Achievement Award. Ganesh Simkhada on stage to honor Professor Mahesh Khakurel sir with Lifetime Achievement Award.